Well, good morning, everyone. I'm Michael McGinnis, Executive Officer of the National Academy of Medicine, and it's my privilege to welcome everybody to this joint meeting of the Digital Health Action Collaborative and the Evidence Mobilization Action Collaborative. This is a special and unique opportunity for us at the National Academy of Medicine to convene two of our collaboratives, which are fundamentally engaged in helping to advance the development of a learning health system and a system that will yield substantial improvements for the health of Americans everywhere. I'm very pleased to thank not only each and every one of you for joining us, but special thanks to the organizers of today's session. This is about health data. It's about cooperating across our sectors and across the nation and to capture, organize, share, and use health data for better health and for new knowledge. It's about, in effect, health data as a core utility for the common good. It's a given and obvious to all of us that health data come from many sources. And those many sources constitute a very complex environment. Complex structurally, complex functionally, complex economically, even at some level, complex emotionally. Data are important as indicators of who we are. Our working assumption then, as we think about moving the health data domain into a presence, a reliable presence as a core utility for the common good, is that there are certain key things that have to occur at the fundamental level. One is to describe the environment. Another is to describe the levers that are involved working within the environment. Another is to identify the principles that can be used to govern the use of those levers for the common good. And that leads to the assumption that we have to advance in our capacity to develop and implement a governance framework and a series of operating rules that optimize the implementation of those principles. Have to do all of that in a complex environment which is very dynamic and in which there are sometimes at least perceptions of competing agendas. So one of our challenges, and we'll be discussing this today, is to change the perceptions as we move about our activities. By the end of today's session, we'd like to have a sense of how these dynamics are playing out nationally and how our collaboratives and the National Academy of Medicine writ large might be facilitative in the progress at hand. The next slide, please. As I mentioned, this is a joint meeting of our Evidence Mobilization Action Collaborative, and here are our chairs of the collaborative, Rick Kuntz from Medtronic and Rich Platt from Harvard University. They're both distinguished leaders in the field, and you can go to the reference documents for more background, but the important issue to emphasize is our gratitude to each of them for their contributions in leadership and putting together today's agenda. And in addition, the next slide, please. Similar gratitude and appreciation for these two important national leaders, Reed Tuckson from Tuckson Health Connections and Jonathan Perlin from HCA Healthcare. These are the co-chairs of the Digital Health Action Collaborative. And so Rick, Rich, Reed, and John, thank you very much for all you've done to put this extraordinary agenda together. Before we get to the agenda itself, I'm going to give you just a little bit of background on the National Academy of Medicine's Leadership Consortium and what we're doing to try to enhance progress throughout the nation in health, healthcare, and biomedical science policy. The consortium itself is made up of stakeholder leaders in private, public, and independent organizations from key health sectors, collaborating under the auspices of the National Academy of Medicine for action on their common interests across the sectors in advancing the effectiveness, efficiency, equity, and continuous learning in health, medical care, and biomedical science. Next slide, please. Together, they work under the big tent, so to speak, goal of advancing the learning health system. And a learning health system is defined by the consortium participants as one in which science, informatics, incentives, and culture are aligned for continuous improvement, innovation, and equity, with best practices and discovery seamlessly embedded in the delivery process. Individuals and families, active participants in all elements, and new knowledge generated as an integral byproduct of the delivery experience. That goes all the way back to our charter at the outset of the consortium's work in 2006. And you'll see, next slide, that we've tried to remain faithful as we facilitate collaborative action to those general foci. Next slide, please. So we have collaborative action enterprises, if you will, that are focused on science, on informatics, on incentives and culture, as you recall from the charter. In science is the work of our Evidence Mobilization Action Collaborative, which focuses on continuous learning through real world evidence. In informatics, the Digital Health Action Collaborative focuses on digital infrastructure and data as a core utility. Incentives, the Value Incentives and Systems Action Collaborative focuses on payment based on health outcomes for people and populations. And in culture, the Culture, Inclusion, and Equity Action Collaborative focuses on full and equitable health engagement for people and communities. If you look across the identity of these four collaboratives, you'll see the common dependence on the data infrastructure as a guidepost, as a source of progress, both a guidance for the future directions, but importantly, an indication of how we're doing now, and a clear and fundamental resource for generating new knowledge. So this session today is important to every one of our collaboratives, and the data milieu in which we work. It serves as in effect, the knowledge and nerve center for operation of all of our health sector enterprises, moving toward a system which is more efficient, more effective, more equitable, and continuous learning. Next slide, please. Actually, let's hold off on this for the, we can go to the next one, thank you. Each of the collaborative has a series of networks that they sustain and work with. These are made up of organizations which together work around anchor principles, and they have a series of key progress indicators that give a sense of how well they're doing and how well we as a nation are doing. And they also sponsor a series of collaborative projects. So the essence of the whole enterprise under the NAM Leadership Consortium is to facilitate collaboration, and facilitate collaboration in a fashion that will ensure that the full range of stakeholders is involved and aligned to the extent possible. We have a very exciting agenda today lined up for you by the co-chairs, and it's my pleasure now to turn to Rich Platt to take us through the agenda. Next slide, please.
Okay, thank you, Michael. And it's a pleasure to be with you. I do want to say that for an appropriate consideration, National Academy of Staff is willing to touch up your photos so that you look 15 years younger. So here we are. This is how we're going to spend our time. We have 3 main sessions today. The first is a framing session that is going to describe activities of the Leadership Consortium that provide context for this meeting. It's divided into 2 sections. The first is derived from the fact that the Leadership Consortium has created 9 sector papers dealing with the lessons learned and opportunities that have arisen as a result of the COVID-19 pandemic. Every one of those sector papers identified data governance as an important need, and we'll hear from leaders of 2 of those sector reports. Nikayla Cook from PCORI will talk about the research sector paper, and Peter Lee of Microsoft will talk about the digital health sector. And then the second activity of the consortium will be described by Sarah Green of the National Academy, talking about the work that the Academy has done on health data sharing, to talk about the demand side of data sharing with some case study work. We'll have a period after that for group discussion. And then we'll move into the second session, which will talk about 2 pandemic-driven developments in data sharing. The first will be presented by David Myers of ARC and Ken Sands from HCA Healthcare, talking about the Charge platform that's been developed at HCA. And the second will be by Ken Gersing of the NIH NCATS program, to talk about the N3c platform. We'll have a period for question and discussion after that. And then the third session, we'll talk about the prospects for nationwide data governance, focusing on achieving an appropriate balance between access to data and the ability to use it for a wide array of purposes, while ensuring an adequate amount of privacy and security. And we'll have 3 discussants there. Mickey Tripathi, the National Coordinator for Health IT, will lead this off, followed by Peter Margolis from the Center for Children's, from the Cincinnati Children's Hospital Center, talking about improved care now, and Amy Abernethy at FDA. We'll have a discussion period after that. And then Rick Kuntz and Reed Tuxson will provide a recap and discuss some action steps with the group. Finally, Mike will close us out. So as we get ready to jump into that first session, could I have the next slide, please? Here are the logistics. We're asking you to keep your line mute. We're asking you to use the Q&A button at the bottom of your screen and indicate, type in your question. It would be good if you could identify your organization, and if you're aiming at a specific discussant, please say that, and we'll accept as many questions and comments as we possibly can. Okay, Michael, I think it's back to you for the first session.
Thank you very much, Rich. And again, thanks to each of our participants. This first session, as Rich mentioned, is strategic framing. And as he mentioned as well, the National Academy of Medicine, through the Leadership Consortium, has been involved in, over the last about 8 or 9 months, in looking at the impact of COVID-19 on different sectors. Next slide, please. The sectors you see here listed on the left-hand side: patients, families, and communities, clinicians and professional societies, care delivery organizations, digital health, state and local public health, health payers, product manufacturers and innovators, health and biomedical research, and quality, safety, and standards. As Rich noted as well, the data issues course throughout as central priorities for progress in each sector. Lead authors are noted by title, not by name, to give you a sense of the very impressive, very skilled, and highly insightful individuals who led each of the sector papers. And we're very fortunate to have with us today the co-lead of the Health and Biomedical Research paper, Nicola Cook, and also the co-lead of the Digital Health paper, Peter Lee. Next slide, please. The sector papers are being released over the course of the next 6 to 8 weeks. This is an example of one, the public health example. There were 2 released on April 7th, Public Health and Care Systems, and stay tuned for the release of the others, and then there'll be a final NAM special publication that looks across the full array. But again, to return to the fundamentally important theme, we will not make progress, the progress that's possible in any of these sectors without a data system that takes full advantage of the many sources of critical health data and makes them available for sharing, analysis, and use for improvement. We also have Sarah Green, as Rich mentioned, who's going to be talking about one of the key elements of ensuring that we are making possible the kind of broad scale use of the data that are gathered. And Sarah Green will be discussing our work on data sharing. I'd like to now turn it over to Nicola Cook. Nicola is the Executive Director at the Patient-Centered Outcomes Research Institute. As I mentioned, the co-lead for the Health and Biomedical Research Sector paper, and she'll be followed by Peter Lee, the Corporate Vice President of Research and Incubation at Microsoft on the digital health sector. Nicola?
Good morning, and thank you so much, Dr. McGinnis, and thanks for this opportunity to present some of the insights from the COVID-19 biomedical research sector assessment that are really going to be relevant, I believe, to the discussions today on creating a health data sharing governance framework. And as Dr. McGinnis mentioned, this assessment and report was co-authored with Dr. Michael Lauer, NIH's Deputy Director for Extramural Research, and we had many contributions from reviewers, which we're very grateful for. Let's go to the next slide. I wanted to begin by what we saw happening during the COVID-19 pandemic in terms of the research sector's experience with data sharing. And in the pandemic, we witnessed the potential for data sharing within and across research and health sectors that could advance processes to nimbly adapt to address the evidentiary needs and support the rapid response that was required, as well as public health and clinical decision-making. We saw a fast and seamless merger of studies. We saw some core governance issues that were considered and perhaps even expressed in their component parts and some solution-oriented approaches. For example, there were rapid agreements based on policy and legal parameters that were developed to structure data transfers and data sharing amongst institutions toward common goals of accelerating our evidence-based information. And we also saw advancement of standards and interoperability. For example, the NIH promoted the adoption of the US core data for interoperability and FHIR standards as critical mechanisms to bring coordination and collaboration to a broad set of COVID-19 research activities, including clinical trials, as well as to promote aggregation and validation of observational analyses using real-world data. And likely one of the most significant drivers of progress during the pandemic was the heightened urgency for data sharing and data sharing systems that were spurred by the pandemic, which provided a window to accelerate progress and allowed a rapid shift in momentum forward in areas that previously required a greater degree of trust. And this shift in the risk-benefit calculus allowed a different determination to be made about how much trust was required to initiate work versus what could be worked through as needs and challenges were further defined or even understood. And for example, hesitancies were diminished regarding issues such as data misuse or competitive challenges to ongoing publication that was really promoted by the urgency of the information need. We also saw that funders required data sharing in all of their efforts, given the gravity of the situation. And centralized approaches to harmonization were more acceptable in this setting. And one of the examples you'll hear about later in the agenda is the NIH National COVID-19 Cohort Collaborative. And we also saw decentralized and federated efforts allowing for the capture of real world data. And one example is the COVID-19 work that was undertaken by the Patient-Centered Outcomes Research Network common data model that's easily queried via a distributed network model. And there was also data aggregation and meta-analyses that occurred out of necessity to enhance the ability to draw conclusions and rigor and enhance reproducibility. Let's go to the next slide. So in many ways, the pandemic itself was a use case for data sharing, and there were many lessons learned. Advancing data sharing and research, we learned, will require embracing opportunities in a crisis for both short and long-term impact. And some of the lessons included the importance of imbuing and communicating trust. And this was just reinforced throughout the pandemic. And as we know, trust is given and not told, and communicating accountability is central to earning and sustaining trust. And as it relates to data sharing governance, lessons about the importance of trust cutting both ways were further emphasized. While a sense of purpose was really clear, there was still a need to have a governance structure to ensure the mitigation of risks related to data use or misuse, as well as reinforce principles of accountability and trust. And a report that was issued during the pandemic with recommendations on data sharing emphasized the establishment of data sharing governance that documents methodologies used to collect, define, and construct data, as well as establish the standards for trustworthy data repositories. And as it relates to incentives, lessons from the pandemic and what we probably knew even before the pandemic is that data sharing within and across sectors is really feasible, and it's not prohibited by technical issues. And it's probably prohibited more by issues of misaligned incentives and ethical and social and legal issues, which we know are really challenging to work through. Yet the experience and solution-oriented approach that we had during the pandemic of how we dealt with even component governance issues will be important to capture and sustain as we move forward. And from a methods and technology perspective, standards, harmonization, and interoperability continue to emerge as truly critical to the path forward. So the real question coming out on the other side of the pandemic is whether we're going to regress to the mean and return to backwards in terms of where we were before, or really use the capitalize on the urgency of the moment to continue the progress that has been made during the pandemic. And I would say that there are still a few critical action steps that lie ahead to promote this sharing of data and interoperability across platforms to help us deliver real-time results in clinical settings. And it's going to require a continued resolve and facilitation of these requirements for researchers to share data and document for analysis and reuse, and consistent with, but not limited to, data sharing policies, which are really the floor. And we want to continue to work beyond that. And we also believe that data sharing governance is going to it needs to require data sharing, but also promote infrastructure that's going to support data sharing and allow for standards that will promote interoperability, transparency, and data security to emerge to really support these aims. And a health data sharing governance framework is going to need to promote donor interest as well, and include stakeholders that are specifically communities and patients that will help generate solutions to the concerns of data use and misuse and privacy. So these are some of the things that emerged in our review of the research sector during COVID-19, and some of the lessons that may be relevant for the discussions today. Thank you.
Thank you very much, Dr. Cook, for a very effective and insightful and if very efficiently delivered set of insights for us moving forward. You're underscoring the issues of requirements and infrastructure and donor interest as important opportunities and essentials for moving forward. Is something that we'll, I know, return back to throughout the course of the day. And so again, thanks for the work on the sector and on this wonderful presentation this morning. Let's now turn to Peter Lee, who will be describing the work in the digital health sector. And Peter, as I noted earlier, is the chief scientist at Microsoft.
Thank you, Michael. It's really a pleasure and an honor to be here. The digital health sector assessment was very interesting. It was also challenging because, as was alluded to earlier, there were no sectors for which digital health was not relevant and a major part. And in fact, as you've just heard from Nikhila Cook, the digital health and data issues, specifically digital data issues, were pervasive, for example, in the research sector assessment. And so as we really dug into this, we ended up having to actually study the outputs of the other sectors very carefully in order to synthesize what have we learned. And our assessment then resulted in 3 parts. One is what were the kind of common observations and challenges across all sectors? Secondly, then what lessons have we learned? And then third, what could possibly be a path forward? Now, on the first part, on observations across all of the sectors, we ended up synthesizing across all 9 of the sectors a number of key points. And I won't go through detail here, but I'll just pick out a few just to give you a flavor for how we saw this. There's no doubt, especially if you go back, say, to the first SARS outbreak in the 2002-2003 timeframe, there's been tremendous digitization of healthcare and public health. In that time frame, for example, we've gone from less than 15% of electronic health records being in digital form to now well over 98%. And that's been a complete sea change. And in fact, we saw during COVID-19 response that telehealth, not just live interactions electronically, but in fact, through automated AI-powered chatbots, through better care continuity, connectivity between telehealth systems and electronic health record systems, and even deeper reach into demand forecasting systems really became real, practical, and essential in COVID response. At the same time, this pressure testing of all of our digital capabilities did show very significant challenges and shortcomings. In fact, the lack of standardized elements for tracking patient encounters, capacity to treat those patients, and utilization emerged as a significant blind spot. And despite the fact that all of the information must have been present in the digital infrastructure for many months, and even today, we have significant challenges in extracting those insights and that data from our digital infrastructure. Another challenge that emerged, you could refer to as a digital divide, not just access to reliable internet, but challenges in language translation, in bridging to communities that have been historically underserved, for example, to understand access to PPE for care at home. And all of these things we would hope our digital infrastructure would provide the necessary knowledge and insight and support moving forward in the future. Now, from these observations across all the sectors, we tried to extract what are the key lessons learned. And our assessment goes into considerable detail on those lessons. And so I won't have time in this short presentation to go into that. So let me just go to the next slide and just give a flavor for things. Oh, one thing about the observations is we did present in the report a table. These X marks are actually bits of text that appear in the full report to give a little bit more detail about the challenges and opportunities. Next slide, please. In essence, pervasive through all the lessons learned was the frustration of having to fly blind. Despite the knowledge that we had this complete digitization and digital infrastructure available to us, we were really unable to extract and answer key questions. Even fundamental questions such as what is the capacity and where will demand appear next ended up being extremely difficult to answer. Technology companies like Microsoft, but many others, in fact, thousands, rushed to address these crises and in amazing speed deployed thousands of new data systems. But those data systems, while locally making an impact, only serve to make the entire digital infrastructure even more siloed and more complex. Next slide, please. And so as we concluded in lessons learned, we had this situation that we described using the rhyme of the ancient mariner of water, water everywhere, nor any drop to drink. We ended up having a situation where, despite nearly complete digitization and so many advances in data analysis, machine learning, AI, and visualization, we remained thirsting for high quality actionable data. Now, as we absorb these lessons learned, there is a fundamental thing that emerges, which is the lack of an architecture that allows us to build new data systems, deploy them in a way that leads to a coherent national infrastructure. And since the co-author, Amy Abernathy, will be talking in the session coming up on data governance, I'll leave it to her then to describe some of the thoughts that we present on the path forward to address this data architecture issue. Thank you.
Thank you very much, Peter. And I should apologize to all of our speakers for the brevity, for the short amount of time you've been allotted to share with the audience and all of us the depth of analysis that you've gone into. But I assure those of you who are not fully familiar with the processes involved that we are working to set up a foundation on which the lessons learned through these activities can in fact be embedded as elements of a strong matrix in the foundation. And you folks who are in the audience are part of that construction project. So as we move to Sarah Green, I want to also urge each of you, as you're listening to the nuggets of insights shared by our speakers, and your thoughts are prompted about ways in which we can improve the design and building and implementing of the architecture that Peter has referenced. Please be in touch, because this is clearly a communal and collective opportunity and responsibility. So again, thanks. And I'll turn now to Sarah Green. Sarah, who is working with us as a senior advisor and comes to us with a wealth of experience in PCORI and working with advancing of the use of data among organizations in a variety of circumstances. Sarah, thank you.
Yeah, thank you, Michael. It's great to be with all of you today. Yeah, this work has gone on alongside the sector papers that I'm going to describe today in just a couple of minutes overview. So I will be sharing insights from our PCORI supported work on understanding the barriers to data sharing, and a follow-up project that's going on right now to identify the bright spots, groups that are identifying barriers and actually taking them on. And I think this will help with our strategic framing throughout the morning. Next slide, please. So I was one of the co-chairs of 3 stakeholder groups convened by the NAM beginning back in 2018 to dig into the non-technological barriers to sharing health data. And it was very intentional to focus on financial, operational, ethical, and cultural barriers in this activity, because we all know that the data wranglers can surmount the technological barriers thanks to things like common data models and APIs and the like. But we really need to focus on the categories of barriers shown here. And the stakeholder groups that were part of this activity included researchers and research oversight leaders, patients and families, and health system leaders. So we really tried to address these different categories of barriers seen on your slide from multiple different vantage points. Next slide, please. And this work culminated in the NAM's report on barriers to data sharing, which we published last fall, and hope that many of you have seen or will take a look at. And in this report, we identified barriers that were unique to patients, health systems, and researchers. And more importantly, we identified barriers that were convergent. And I won't go into the unique stakeholder-specific barriers in the interest of time, but if you take a look at the next slide, you'll see that the chief barrier common across all 3 groups, right there in the center of that Venn diagram, was a lack of trust, which dovetails beautifully with Dr. Cook's remarks a few minutes ago. And so regardless of stakeholder type, there were concerns about trustworthiness that related to how and by whom health data were being used. And so along with identifying priority barriers, which are there on the left side of your slide, we also identified 7 action steps that are shown on the right side. We prioritized a number of actions that we thought could be completed in a shorter time horizon of about 2 to 3 years. And the one I'll focus on briefly was to surface these case studies. In the barriers report, we heard a lot about nobody wants to go first. And so we sought to identify vanguard groups who are successfully sharing data across different partners, different stakeholder groups. And in doing so, they are tackling many of these barriers. Next slide, please. So we have compiled 11 case studies that are responding to these barriers, as I mentioned, researchers sharing with industry, healthcare providers opening up their data to patients, competing health systems in the same market, partnering with a payer to identify a data utility and create that utility in order to support value-based care transformation. We also sought 2 case studies that are catalyzed by the pandemic, and you will hear, as was noted from Dr. Gersing later today, about the path-breaking work of the N3c. And so I don't have time to tell you about all 11 of the exemplary groups that we're studying, but I would like to offer a couple of key themes that we're seeing across the case studies. The first is that many of the groups that we spoke to said in no uncertain terms that the status quo of data in silos underutilized is no longer acceptable. Several interviewees described this as almost a moral imperative. And if you go to the next slide, there's a lovely summation from one of our interviewees who said, every single touch point in our health system provides information about our patients and populations. If we just let it sit there, we're not fulfilling part of our responsibility to them. And we heard variations on this from virtually every case study interviewee. And frankly, as we all know, entire companies are now being formed and well capitalized on the premise that democratizing health data is absolutely the way forward. Next slide, please. A second theme we've heard in the case studies is heartening to all of us. I think it will be to all of you. Nearly all the groups we've spoken to have expressed a very strong desire to share what they're learning along the way, creating a roadmap for others. And that goes back to that point earlier about somebody needs to go first in this space. And so, to be clear, turning the tide altogether from a mindset or a philosophy of data guarding to data sharing is going to require an evidence base along with a business case. So we're gratified to see a steadily growing literature on the attitudes and practices related to data sharing so that others don't have to start from scratch. And next slide, please. I could go on about this all day, all morning, and I look forward to working with the NAM to release our case study report later this year. But I want to just close with one final point. It's incumbent on all stakeholders to take this on and ensure that how we act with respect to health data engenders trust through our actions and act in a trustworthy way with and for our patients, our families, our communities. And as you can see in this quote from the Barriers report, even though a lot of the energy around health data sharing is focused on policy, this is really truly about people. And when we presented this work earlier this year at the National Health Policy Conference, my colleague Peter Margolis, who you'll also hear from later today, aptly noted, trust cannot be regulated, it has to be cultivated. So I hope we can use conversations like today's to continue the journey of cultivating trust and make sure that it's wholly embedded in all of the health data sharing activities that we undertake. Thanks so much.
Thank you, Sarah. The ending point is important watchword for us too, as we work on that data architecture and the modules that are represented within it, that we always keep the patient lens, the individual lens firmly in mind as the North Star and anchoring concept. That's the only way we'll generate trust. Thank you again for your work and for this very nice presentation. We now will turn to the next session on insights driven by the burning platform of COVID-19. Here we'll be looping back on many of the themes that have been introduced by Nikayla and Peter and Sarah. And I'll turn it over to Rick Kuntz and Rich Platt, who will be moderating.
Okay, this is Rich Platt. I'll kick us off, and Rick will moderate the discussion. The two examples that we're going to talk about today highlight two basic philosophies about ways to share information. The first is going to be presented by David Myers and Ken Sands, talking about the CHARGE Consortium. This is an example of data that stays home, and they've developed a very clever and innovative way to allow a wide array of investigators to work with it. And the second example that will be presented by Ken Gersing of the N3c initiative, in which data is aggregated from a variety of sources and then made available to investigators from a central place. So leading off is David, who is the acting director of the Agency for Healthcare Research and Quality. So David, please.
Thank you so much, Dr. Platt, and to Dr. McGinnis and the whole leadership consortium for inviting us here today to share with you. Can I get the first slide, please? Oh, there we go. So next slide, please. To put this in a bit of context, the agency that I have the privilege of working at is part of the HHS family of health research agencies, and our focus is on care delivery itself. Next slide, please. Our aim is to think about how healthcare systems and the professionals who work at them, how we can support them in providing so that they can provide higher quality, safer, more equitable, and high value care. And we do that through three interrelated streams of work: generating new evidence, developing tools and resources to get that evidence into practice, and then using data to help show where we need more evidence, where are the gaps, how is the country doing. So next slide, please. We were thinking along with the National Academy of Medicine about a series of interrelated barriers over the past few years to get towards this mission. And the first was how to catalyze the creation of learning healthcare systems that use data provided in the process of delivering care today to improve the quality and safety of care delivered tomorrow. We went further and we're asking, how do we put, as a health services research agency, how can we help embed researchers and the research methodologies that they use into clinical delivery systems so that the questions answered through research are more useful and relevant to system operations, and so system decision makers themselves get more actionable and valid answers to their questions. And finally, our third question, which we heard earlier in the presentations today, is how do we free and silo data from individual healthcare systems to allow more powerful data and data analytics? Excuse me. So we were extremely excited when Jonathan Perlin of HCA approached us with their idea for a potential partnership. Next slide. So who is HCA? A few words about them. They are one of the largest delivery systems in the United States, operating in over 180 hospitals in 21 states and caring for a population that reflects the diversity of our nation. In 2009, HCA invested in building its own comprehensive clinical data warehouse that aggregates data from its disparate EHRs across its entire system. And they've been using it for over a decade now internally for quality improvement and learning. But the COVID pandemic provided new motivation for them. Next slide, please. The HCA team recognized that they were sitting on a mountain of information on the experience of hospitalized patients with COVID-19. Throughout their network, they had cared for over 100,000 inpatients. And so through their data warehouse, they recognized they had one of the largest data sets in the world, potentially, about inpatient care for people with COVID-19. And they built a registry that they update daily, drawing from the data warehouse from patients that they have seen from March of 2020 all the way through today. And HCA came to ARC and said, could we think with them about how they might create a long-term collaboration that it would allow external researchers to come in and use the HCA data registry to expand the nation's understanding and provide evidence on the best management of COVID-19. We jumped at this chance. Next slide. HCA leadership was interested in moving beyond doing this, though, as a one-time data analytic project, and really saw this as an opportunity to build their own infrastructure for future collaborations, aligned with their efforts to become a learning healthcare system. Next slide. So in addition to reaching out to ARC, HCA reached out to research teams that they had worked with successfully in the past. And then ARC brought to the table a National Hospital Medicine Research Collaborative new to HCA, but that had done important work about inpatient care. And from the beginning, when we sat down at the table together, the interest in working together and working quickly was tremendous. Next slide. HCA offered these external researchers the opportunity to access a limited data set derived from the full HCA data warehouse and its registry, and then also to supplement that data as necessary for individual projects by drawing back up into the data warehouse. Next slide. I think some of the most important work that is coming out of this project is the model for data privacy that HCA has created for this. And this is a complex slide and we can come back to it later, but it shows the importance of privacy in establishing this entire relationship. It's a partnership between HCA and their research institute. They developed the limited data set and the partnered research institutions. On the left, you can see one model that's being used, which is using noise injection, creating synthetic derived data sets that can be made available to the researchers to play with as in a sandbox. So as you can see and see in the middle, they can develop their analysis and the model that they want to do. Once they have that model, they can either, there are going to be two potential different pathways, through differential privacy protections, pass their query directly to the LDS. So HCA checks to make sure that the query itself is safe, and then they get back their answer from the limited data set. Or in cases where it's identified that that is not enough protection, they pass their information directly, the analysis plan, to the HCA analysts themselves, who inside the system runs it on the full data set or the limited data set, and then passes back the answers. And then together, the teams make sure that the results are published. One of the important things to recognize here is that as we think about this, data itself is not the only valuable commodity. It's knowledge about how the data is organized, the data architecture, and that the use of HCA bringing their data scientists into the process is what is going to make the external research with their methodologies work together to produce meaningful answers. Next slide, please. So on the next slide, we're going to see the focus of today's conversation, further some of the governance issues that were brought forward. Charge itself through a formal signed memorandum of understanding between each partner and the HCA healthcare system and its research institute. That was a process, but as Dr. Cook said, the urgency moved to this much faster than anybody could have thought possible. The lawyers moved this within weeks to establish charge. HCA, however, in this model, as Rich Platt just said, maintains full control of its registry data sets and their use. The MOU establishes a consortium steering committee, which I'll show in a moment. A common IRB framework was established using HCA, and all of the research institutes, thanks to the leadership of NIH, were able to sign on to use that framework, which is speeding up the research. The steering committee reviews all research proposals. This is creating more methodologic rigor. They provide initial enthusiasm ratings, similar to the way a federal funder might look at proposals. The great news is that so far all of the proposals have been of such high quality, they've moved forward, but HCA retains the ability, the decision-making power to say whether or not their data can be used for the study. But very importantly, once they agree to the methodology of the study to go forward, the memorandum of understanding protects academic freedom and the eventual release of the finding. The consortium meets regularly with its steering committee, addressing additional issues about how to make things go faster and better, including already starting to think about how this data set and this infrastructure could be used for future research projects. Next slide, please. Here's the basic model. Everybody who's part of this is on the steering committee. Individual working groups are set up for each project. Next slide. One thing that's very important to recognize again is that this whole project works because of the leadership HCA has made and the commitment and the financial resources they put out, not only for their data infrastructure they're providing, but for the skills of their staff to keep moving this forward. Next slide, please. I really believe that the project is working, as we've heard, because of the urgency of the pandemic, allowing trust to be built quickly among HCA and these external research organizations. I hope and believe that having ARC involved also helped, as a convener, has also helped add to that trust, and that building trust and maintaining this trust is going to be critical to the long-term success of Charge. This slide, as you've been reading, just shows how a study goes from conception all the way through to peer publication. Next slide, please. About 7 studies are already in process within the first 3 months of Charge as an idea to being formed. These studies are all now moving forward. If you look over on the right, you can see most of the studies, as you'd expect, are focusing on understanding clinical care for COVID-19 patients in the inpatient setting. But they're also moving forward on things of methodology, really important things about how to use data and machine learning, also recognizing that COVID-19 unleashed other and the experience is showing other things, so non-COVID care related to antibiotic use and its effect in the hospital. And finally, people are already starting to think about how this work can lead to other work in the future. Last slide. I wanted to just sum up next with some observations here. This case study, I hope, will show you again and underline how the pandemic motivated folks to come together to overcome previous barriers to data sharing. But this particular effort is made possible because of the willingness of a large healthcare system to invest in this project. Their decision to do that, however, allowed them to keep control of their data and its uses. So both a positive step forward, but also potential limitation for expansion of this kind of model. The research teams also, though, showed that they were willing to come and partner. They had trust, and they're doing this without additional funding, I think also motivated by the need to move evidence forward. The methodologies of data sharing here are really exciting and novel, and I think will lead to future disseminatable lessons. Thinking forward, the next step is going to see if Charge can evolve to welcome other health systems to contribute their data. That'll be a major step forward. And finally, the sustainability of this project and the data sharing infrastructure moving forward will need to be determined. with that, I'll pass it to Dr. Sands. If you'd like to add anything, it was his company that did this.
Thank you, David. This is Dr. Ken Sands. I'm Chief Epidemiologist here at HCA and sitting in for Dr. Perlin, who had a conflict at this time. We think that this is a really exciting initiative. We're happy to be able to pursue this. There's already been a comment around the moral imperative of making this data available, and that was definitely something that inspired us to go down this pathway, since we do have such a large experience with the HCA experience with COVID. At the same time, we do have a long history and commitment to the learning health system. I see that there's a question coming in about the Sentinel project. That's a long-term relationship that we've had that has also yielded benefit to HCA and to the learning health system at large in terms of generating information in relation to medication outcomes. And then finally, we see direct benefit to our organization in terms of early access to the newest information, which helps us operationally, as well as engagement with clinicians and a source of pride to the organization. So this has been a win-win for us, definitely a learning experience and very exciting. Thanks for the opportunity to speak.
Okay, great, thank you. Next is Kim Gersing from Enclaves, and it's going to talk about the N3c program.
Thank you. Next slide, please. Thank you. So just for the folks who don't know what NCATS is, and specifically the CTSA program, just a quick words about this and something called the idea states. NCATS funds something called the CTSA, which are 60 or so of the largest academic across the nation. If you count collaborators and partners, this is well over 1,000 institutions. We have partnered with community hospitals, FQHCs, and something called the idea states that are all out of general medicine at NIH to collect data across the nation. So these stars and diamonds are where data is coming from for the N3c. So next slide, please. So so what I'm going to really describe is what we did, and I first should say it should not stop saying or say thank you, but what I thought I would do is talk about some issues that we had throughout the process in what we've done, successes and failures, and things we need help on, because the goal of this group is so important. So when the pandemic hit, we have as I showed you in the map, we have a pretty large reach across the country. We said to all of our members of these communities, we want your data on people who have COVID, who've had COVID, or controls, people who have not had COVID, and we want their entire medical record, and we'd like it starting in January of 2018. And for every one COVID you give us, we want controls. And we know that everybody is busy, so you can give it to us in any common data model that you want. And it's, to some degree, any data model that, as long as it's one of these 5 flavors, you can give it to us in OMOP, ACT, Trinetics, Cornet, or FHIR, and we will take that data and harmonize that data and put it in an analytical model. We chose OMOP and place that in a centralized repository. And one of the reasons we chose a centralized repository is because they're, federated networks and centralized networks are actually hand in hand. They both have strengths and they both have weaknesses. But one of the strengths of a centralized model is we can control the harmonization of data, but also for things like machine learning and rapid turnover of research, it facilitates that. So we harmonized the data, and it was about 2 million individual items that we harmonize from these different data models of values, value sets. And next slide, please. And so we started, actually last week was our year kickoff. And you can see over time where we are. This slide ends in March because we're still in April, and I can update you on some of the numbers. But right now we have, in April, we have 86 institutions that are giving us their data. We have 100, actually, again, we have, and we call those data transfer agreements, something we need help on. We have 186 on the slide, but 197 organizations using the data. We call that a data use agreement. We right now have closing in on 300 active projects that are using the data. The slide says 47 sites of the 86 are available. As of today, it will be 52. The reason the difference between 52 and 87 is because this is a cleaning exercise and we only release probably about 2 to 3 a week. We've organized the N3c into what we call domain teams, which are like groups of clinicians, or like we have a COVID in neurology, COVID in kids. We also have some cross-cutting domain teams on machine learning, NLP, and data quality. NC3 is published or in preprint well over 40 articles. Next slide, please. So as of last week, and this week we'll have 2 new sites, we have a 1.2 million COVID patient EHR data. That's almost 5 million patients, and we'll pass that this week. Again, it'll be 52 today. We have 6 billion rows of data, almost a billion drug exposures. The data is very representative of the population, both rural, urban, socioeconomic, ethnicity, race. We have well over 1,200 active researchers every day, and there are 2,000 people that have contributed to this effort. Almost 95% of them have been completely voluntary, and I can't help but I'm humbled. The pandemic was horrible, is horrible, but it has also showed the best of humanity that this many people would work together to make. Next slide, please. So let's start talking about the governance of it. And again, some of these slides are meant to be hopefully fodder for the questions. So the data, the way this slide reads, and sorry it's so complicated, is on top is how we're getting data in. So institution-sided data transfer agreement, it comes into us as a limited data set, very much like Hca, which includes true dates, true zips. We do the harmonization. Harmonization is quality harmonization. I won't go into details, it's not appropriate for our talk today, but it is the key to making this data worthwhile. And I should mention that the harmonization infrastructure that was built, the reason we were able to do this in about 3 months is because we had started this process many years ago with FDA, ONC, NLM, NCI, so that we use that as the underpinnings of this. So the data comes in and we make it into 3 flavors that are available to everybody. You can get a synthetic data set, you can get a de-identified data set, you can get a limited data set. So now start from the bottom and go up. How do you get access to the data? Well, your institution use agreement, the data use agreement then allows anybody in that institution to use the data. Investigators submit a 1-page proposal. We have a federally staffed data access committee that reviews it. And then depending on what you're asking for, you're given access to one of these 3 flavors. Enclaves pays for all data usage of the data, this GPU. It goes into an enclave, a enclave, and for people who are interested in security, it's a FedRAMP moderate certified enclave, and it goes into a tool called Palantir. The enclave is, as my boss describes, much more like a hotel. The data checks in, it never checks out. You have to bring your tools to the data. You can obviously export your results graphs. These are all reviewed for privacy, but the data stay within the enclave. We are working on exporting the synthetic data, but we're still doing quite a bit of evaluation on 3 different vendors that are creating synthetic data. Next slide, please. So just real quick, it's getting access to the data. Just to review, is you register, your institution signs a data use agreement, you register. Everybody has to take human subject protections training and security. We pay for those. And then you submit your data use request. The access committee reviews it, and we set up an enclave, and you're given your data set and you're off and running. Next slide. It was, because it was a pandemic, we wanted to make access to this data as easy as possible. Really, anybody who wants to use this data, it's available. It's, like I said, it's free. But as part of your code of conduct and data use agreement, you have to agree that you're not going to use the data. And in essence, you're only going to use it for COVID research. You're not going to try to re-identify people. You're not going to re-download it. You're not going to sell it. And importantly, you're going to share back all insights to the rest of the community. Insights can be anything from a concept set, which is a collection of information you put together that represents, for instance, the diabetes, or it could be an algorithm on how you're predicting severity. So everybody has to share everything. Now, we actually can't and don't. It's a federal resource, and therefore everybody can access. There is no, this is more of a request. I mean, people can say they won't, but that is not the culture that we're trying to establish. It's supposed to be completely open science, including all project results are available on the website, so you can see them even as they're working, and join the teams. Next slide, please. So just, why would you collect all this data? I just wanted to show you a slide that is, there's some value in it. This is one of the, this came off one of the original papers, a cohort paper. And this just shows how we use machine learning to predict severity of patients' hospital stay on the first day of entrance. By using a machine learning, we went through many variables. You can see the list if your eyes can read the small text, sorry about that. And then, came up with the top 10 things that you need to look at for when a patient hits the door. We rerun this periodically to make sure that the random forest, it stays accurate and representative, because the population has changed, and it has. I have another one that was just rerun after this one, the March to May, June to October. We have one that will come out in this March again to just show that it has remained accurate. It has changed a little bit over time, particularly with the pediatric population. We have about 114,000 medical records on COVID kids. And so that's actually took a little bit of changing for the machine learning. Next slide, please. And some, just other things. Severity is tracked over time on all people in the system. And this is just watching the small squares on the right, like hydroxychloroquine on the upper row. You can see how hydroxychloroquine was used quite a lot initially when people were talking about it. It was in the popular press, where other medicines have trended, either up or down depending on the severity. So, some very practical public health outputs, but also some much more non-hypothesis driven work is going on. Next slide. So, including, and now I'm starting to get to some asks. And when we talk about access to data, I think that when I talk the data use agreement, the data transfer agreement, I think that those are some of the things that we've started to talk about already in this discussion, but there's actually a lot more problems with governance or help we need with governance other than that. Within the N3c repository, we have many external data sets. There's just a list of a few of them. We have about 25 of them, and they're always increasing. And these are used a lot for social determinants of health. So this data is linked to the N3c data, and so because I think the way I would describe EHR data, it's necessary, but not enough. We need to link EHR data to other things. This is almost cliche, but a human is much more than their visit to a physician or to a hospital. You know, do they pay their taxes? Do they go to their job? Is there pollution in their neighborhood? Is their neighborhood safe? So having these other data sets with available and to be able to triangulate is really important, but it brings up yet another governance issue, because now instead of saying you have access to the N3c data, which is all in a federal enclave, you have access now to outside data sets. So initially we've started with public data sets, US Census being a great example. But as we're expanding, like we're having CMS data, we're bringing in mortality data, we're bringing variant data. How is the governance of that data from other places to be linked, and then would the local institution that the investigator is coming from believe that right now to get access to the limited data set, you have to go back to your institution and get a letter of determination before we'll give that to you. You can get access de-identified without that, but as the external data sets come into N3c, some of them will require special thought, because if you combine two data sets, then potentially your risk of privacy are higher. And so I think that, and then what data sets do we bring in? What are the important ones? What are the ones that we trust? And so I think it brings up yet a whole nother governance, and that is the governance of sharing different data sets as its own governance issue. And next slide, please. So now I'm going to talk about, I decided I would challenge or do something relatively, hopefully provocative a little bit. So we've implemented something called a PPRL, or privacy preserving record linkage, where we're doing this for multiple reasons. We need to deduplicate data. We need to allow for cohort discovery, but it's also can be used for linkage. And so what this slide is showing, and I won't go into the details, but the N3c data is being combined with omics data or imaging data, and we have to make sure we have the right person. So next slide. So what this brings up is, if we were originally in N3c just talking about the N3c silo of 6 billion rows of data, it's one thing. But now if we can link data, we have from another enclave. In this case, we're linking with a group called MIDRC in Chicago, funded by NIH's NIBIB. And there's the omics data that's coming from yet another vendor or group. So what is the governance of linking enclaves? I told you, talking about the PPRL, even though I was going quickly, is that we can technically do this. And this is what we're doing. We're pulling in that data from those different types of enclaves, linking them with that PPRL, putting them in the middle. It's called an HPC, a high performance computing environment, where the federal analytics is shared, and then that is just FYI goes away after the analysis. But what is the governance of sharing between enclaves? And an enclave could be from anywhere. And then this also brings up a cost issue, because a high performance computing environment is not a cheap thing. Department of Energy, because we're in the federal government, but this is not a GPU. We think of computing power goes down, but the GPU usage has actually not gone down. So the cost of cycles is expensive. So next slide, please. So this is the use case that I'm really talking about. The investigator at the bottom, Jane investigator, said, I would like to perform multimodal analytics across institutions or data sets. And some of the data on the left is coming from N3c. And some of the data that Jane investigator is coming from the Cancer Archive, for instance. And if Jane has access to N3c data, does Jane have access to the cancer archive? And does Jane have access to both of them at once, which is in and of itself a different question. And what does Jane have access to even within it? What is the row level data that this person has access to? So when we start thinking about permissions and access to data, it's much more than just your hard drive, large as it may be. It's actually sharing hard drives, because no group, N3c or any other group, will become the data palace of all health data. We have to understand that it is a distributed world, and we are going to need to share. Next slide, please. So I just wanted to say why we would do this, combining data, because I don't think it's obvious to some folks. And this is actually data being combined, N3c and NCI data on, and this is unfortunately a person who passed away. But what you're looking at is their chest x-ray over time and their N3c data, and you can see and follow their labs over time. And what we're doing is we're syncing that up. And why would you do that? Obviously, I was saying you need to triangulate information because EHR data is actually in and of itself not complete enough, I believe, that's opinion. And there have been articles that have come out about predictive analytics rising well above, going from high 60s to 70 to 90% with imaging data and adding other data. So I think there's a clinical imperative to start to, put that human being back together. Couple other things I wrote down on my notes to say that other challenges we had is that everybody who joins the N3c, we make them have something called an Orcid Id. This way, no matter when you build these objects, which the community shares, an object of diabetes, an object of azithromycin, whoever builds it or builds the algorithm, their Orcid Id is automatically attached to it. So if anybody else uses it or publishes it off it, they get attribution. I think that this is an understated problem of governance. The need to give attribution to the data wranglers who are just as important as the scientists in preparing the data and getting it ready to go or building these knowledge objects. The other things I wrote down that have been surprising challenges for us, good challenges, is that there are some algorithms that are now being exported. And they cross multiple institutions because we have, 190 institutions using this data now. And they include groups from pharma and high tech and biotech and academics. And how do these algorithms that are worked on, who owns them? What kind of license should they go under? How will institutions react? Different institutions, potentially even competing institutions, building something together, and how will that be shared? And another very odd thing we had is we put out one paper where we had 200 consortial authors because they had worked on creating the data set. And the journal said, we can't take 200 consortial authors. In physics, this is a common thing, but it's actually not a common thing in medical journals. So next slide, please. So, and the last thing, I think this is my last slide, I just wanted to talk about, where does synthetic data fall in this potential? For folks who aren't familiar with it, this is, it's a potential get out of jail free with our conundrum here. Because if it's true, synthetic data, which is computer derived data, is releasable. We know that we can prove, or we've been working on 6 months putting out information on its scientific validity, and it looks pretty good so far. But we have not yet showed its privacy preserving ability. So until we have that, we cannot allow the downloading this. But I do think it is something we should consider. Next slide. Yes, I think that's my last one. So I just want to thank everybody for allowing me to talk. And I think this N3c has been a success for the community activity, but it's also shown many of the challenges that so many people have already spoken to. And we would love your insight.
Okay, thank you. Thank you very much, Ken. So this is still Rich. Rick, your charge is to lead a discussion, but we are very short on time, so I'm going to hand this hot potato to you to decide how much discussion we can have, when to hand off to the next session.
Thanks, thanks, Rich. Michael, do you have any guidance on this? How far are we over? Do we have a few minutes, 5 minutes maybe?
Why don't we take 5 minutes of discussion, questions?
Okay. All right. I jotted down about 10 questions. I'm sure everybody else did. This is an extremely compelling presentations and very exciting. Obviously, there were a lot of presentation or questions from the audience as well. Let me just start with one, and actually I'll kick this back over to Rich. Can we just talk about the comparability of the methods and governance with Sentinel and what we're doing in N3c?
Sure. So right now I'm wearing my Sentinel principal investigator hat. Sentinel operates under FDA's Public Health Authority, and HCA, it's a large distributed network. The participating organizations readily agreed to share their information with FDA, but we're not in a position to create the kind of aggregated data set that N3c is creating. And so for each organization, including HCA, has created an enclave, and it receives queries and responds to them if it wishes to. So under the Public Health Authority, HCA has been providing reports to FDA for years, and specifically with regard to the COVID pandemic. Every other week there's a set of detailed reports that go to FDA from HCA. Ken is a principal partner in that activity, so Ken, you may want to speak as well. And I'll just mention that we can add to show notes an article that describes how that works.
Yeah, the Sentinel project has been something we've participated in for quite some time. The queries are very structured. They arise from outside of HCA, and we respond to them. I think that the charge project and data set is more designed for broad-based discovery, and has that sandbox principle made possible by the new technology relating to data privacy. So it's a different model, different data standards, I would say, but similar in terms of combining information from multiple disparate sources and creating a way to access that information.
Great, thanks. Maybe I'll ask a question to summarize some of the other questions in the audience to both Ken's and maybe David. Given the special learning platform aspects of COVID, you had a lot of permission to do things out of the ordinary because of the burning platform. Given the governance you created, the sharing capabilities, and a lot of manual work that you did, how sustainable and scalable is this method after we get through COVID, do you think?
We built this to be scalable. I mean, we're using very much commercial scalable products from Amazon to Palantir to scale this. We are at 6 billion rows, and we have well over 1,500 people in it every day. We do not see this as a scalability problem. It is a financial scalability problem, not a technical scalability problem. This was not a cheap exercise. We've had an army of people volunteering, but if you had to pay them, that would be a very large bill.
Yeah, my comments would be similar. The way we've designed our COVID data set could be adapted to other applications quite readily. And I think that we're basically in discovery mode in terms of best approaches to data privacy, but that seems promising. It's a scalable model, but there is a resource component, a financial resource component that would need to be addressed to make this truly large scale going forward.
And Rick, my point would be that who the value accrues to is very important when you think about sustainability. And for Ken G's work, that's the federal government thinking about public health and what we do about data. And for the work for HCA, it's thinking about how individual learning health systems use data and the ability to invite researchers in. And that I think it's just a different level problem, but the sustainability of if the health system can learn to improve quality, safety, value, efficiency, patient-centeredness through the inviting of researchers in, they may have the motivation to keep sustainability, not spreadability, but internally keep this going. And I think that's what HCA is looking for, is can they, by bringing in researchers, by creating this sandbox, do they entice the researchers to come in and help them improve? And are the researchers excited enough by this opportunity to get access? And I don't know if that works for small systems as well as it does for somebody with the size and reach of HCA.
Well, thanks. That's an optimistic response, and really look forward to this developing into other scalable platforms. Michael, I think we'll kick it back over to you.
Thank you very much, Rick, and thanks so much to the panel, which was it really gave a sense of how we might begin, even though it's complicated, move toward the kind of data access and sharing and productivity that is envisioned. Our next panel is going to be moving into that issue specifically, nationwide governance, progress and promise. Again, we have a terrific group of people who are going to be sharing their insights and their vision with us, as well as a sense of the activities underway and how they might be integrated. And we have to facilitate the conversation, the co-chair of the Digital Health Action Collaborative, Reed Tuckson. Thank you, Reed.
Thank you very much, Mike. And given the press of time, I'm going to keep the opening comments very brief. But as detailed in the previous sessions, forward progress with regard to advancing a national framework for health data governance is altogether necessary if we're going to transform America's healthcare and biomedical science systems. We've learned in our journey toward this transformed future that we've got to learn from catalytic events such as this COVID-19 pandemic, as we have just been describing, but also use prior efforts to inform our path forward. This session aims to explore prior efforts to promote health data sharing for research and for improved health outcomes, while being attentive and protective of privacy and security, and also the need to identify key areas of progress and promise therein. To do so, we're lucky to be joined for the presentations, a panel discussion, and a Q&A with Mickey Tripathi, PhD, National Coordinator for Health Information Technology at the U.S. Department of Health and Human Services. And we are really, really happy to have Mickey here with us. We're also pleased that Peter Margolis, Dr. Peter Margolis is here, co-director for the James M. Anderson Center for Health Systems Excellence at Cincinnati Children's Hospital Medical Center. And he also serves as scientific director for the International Improve Care Now Network. And finally, we are also very, very grateful for Amy Abernathy. Dr. Abernathy is the Principal Deputy Commissioner of Food and Drugs at the FDA. And so we will hear from them each, and then we will have a chance to query them. So Mickey, it is all yours.
Great. Thanks so much. Really appreciate the opportunity to be here. So this question of national data governance is a complex one, and maybe the best thing for me to do is raise a set of questions rather than a set of answers, and we can bat those around. And I think this comes at a great time, right, for us to be thinking about this, because we've climbed a big mountain over the last decade. I think as many who are participating today, realize with the passage of high tech and $40 billion in public investments we've made, as well as at least that amount in private investments in EHR technologies, that are now adopted by over 90% of hospitals and ambulatory practices across the country. I'd venture to guess that there probably isn't as large a project of taking such sophisticated technology and having it adopted by as large and fragmented a group of disparate users, really in modern memory or modern history. I know that feels like a huge statement, but I don't think it's an overstatement when you think about what's been achieved. It's somewhat breathtaking in its scale and scope and speed over 10 years. So, not surprisingly, I think in some ways, especially with regards to the speed with which it's happened, which is really 10 years for one of the most complex, if not the most complex part of our economy, technology has outpaced policy, right? And so now we're trying to figure out, what are the best ways for us to move forward, both from an industry perspective as well as from a government perspective. And I like to think about two dimensions of it. One is the patient-controlled information piece of that, and then the other is the uses of de-identified data. And the definition of which is increasingly shaky. And I think the patient-controlled, part of it is that increasingly more and more information are sort of permeating the membrane of HIPAA and then being made available through the patient themselves into research and other types of avenues, which presents itself a set of privacy issues as well as governance issues as well. Very, very decentralized in that case. So regarding patient-controlled information for a second, just a reminder to everyone, the information blocking rule went into effect on April 5th, 2021, just a couple of weeks ago. And with that, providers, health information networks, technology developers have to start sharing data as per the requirements of that rule. Patient access is a significant part of that. It's not the only thing that the information blocking is about, but it's certainly a significant part of that to be able to enable that. And the high tech created the Ehr Incentive Program and Ehr certification in February 2009. And I think as we look at it now, we sort of think, well, gee, this app thing is real. The platform business model, apps, and that's just now being made available. And maybe we should have thought about that more as we were embarking on high tech so long ago. But I'll just point out that when high tech was passed in February 2009, the Apple App Store and the Google Play stores, each of them were launched less than 6 months before that. So this whole idea of platform businesses and apps ability to improve user experiences in different platforms, as well as be able to have something that's very familiar and accessible to individuals, was very new at the time, really just nascent. So we're all now trying to figure that out together as we move with the information blocking rule that essentially says we should open that up through a set of APIs that are familiar to industry, are familiar to almost every other part of the internet economy, and are made available to researchers, providers, as well as patients. ONC doesn't have authority over privacy policy. Hopefully everyone recognizes that, but we obviously have a huge interest in it because we are encouraging the use of mechanisms that allow patients to pull their data through that membrane, as it were, and outside the protections of HIPAA, often in circumstances where they may not even be aware of it. And in some cases where commercial interests have distinct interest in nudging them away from such awareness. So that's a whole set of issues that I think are really important for us to grapple with and for us to really understand. The other question is regarding other uses, which I think is a huge area as well and a real governance challenge. We've got this solid EHR foundation now. Our implicit understanding, I think, for a long time was that would be the basis for a learning healthcare system. We didn't really operationalize that because it was too early, but now here we are operationalizing it and understanding that there are some real challenges as you start to dig into that. We assume that well-established mechanisms of things like de-identification or explicit consent would be relatively clean ways of doing that. But then as you start to dig down deep into it, you start to recognize that there's a lot of very, very complex issues that start to present themselves really early in that digging. So one is whether data can be practically de-identified. I think that's a more questionable concept than it ever has been before. I mean, all of us remember Latanya Sweeney's famous discovery of Governor Bill Weld's records from de-identified data more than a decade ago, I think. But I think that there was a lot of friction in the ability to do that at that time. But now we're at a place where you've got advanced algorithms, you've got the ability to cross-match data with data gotten from other sources, that it really starts to, just starts to challenge the very notion of de-identification as we thought about it and presents a data governance challenge in and of itself. The other concern, I think, is that information available outside of treatment, payment, and operations can now be pieced together to create inferred medical records. That's data from consumer wearables, from public and semi-public databases like credit history, purchases, the cars I've owned, my house, with the houses I've lived in. And then, of course, the so-called data exhaust for my day-to-day activities, locations, search history, social media, all of that. All of that means that we need mechanisms for creating a learning healthcare environment based on privacy protection that right now are inadequate to the task. So that's the challenge for all of us. A couple of things that might be opportunities for us as we think about this is one, guidelines. There are a few guidelines and codes of conduct that have been put out there by various organizations, all of us and NIH, the Center for Democracy and Technology, and the Health Initiative, the Karen Alliance, all are trying to grapple with this issue of how do we have the ethical uses of data outside the protections of HIPAA. Organizations themselves can, through their contracting mechanisms and data use agreements, put protections on that data in ways that can preserve privacy. And I just was able to hear the tail end of what HCA is doing, for example, in the notion of federated query and being able to have models where the algorithms come to the data and only make results available, not the data itself, or our way of being able to deal with that, for example. And then finally, I think that we shouldn't overlook the opportunity for networks as we think about TEFCA, the Trusted Exchange Framework, where that's really about interoperability governance, but that quickly gets into a conversation about data governance as well. So, for example, in the absence of a more universal data protection policy or data privacy policy in the US, could there be data that we might think of as TEFCA data, for example, that has certain protections on it, simply as a function of being a participant in a network? That starts to unravel really quickly once you start to think about the complexities of deep and granular data provenance, about the relatively lack of ability of being able to tag that data. So once it starts to go a couple of hops, all of a sudden your governance ability starts to attenuate. So those are some of the challenges that we're looking at. As I said, I'm going to raise more questions than answers. Really look forward to the discussion, though, and hopefully that gives us all a little bit of food for thought.
Hey, thank you, Mickey. That was outstanding. Peter, your turn.
Thank you, Reed, and I'll take the first slide. So I'd like to start, and you can go to the next slide, please. I'd like to start with a brief scenario that reflects the perspective of what the current system for data sharing looks like on the ground. So imagine a pediatric department chair is asked to make a decision about participating in a data sharing network that's been proposed by a junior faculty member in a department who's interested in rare disease. He knows he won't make progress without data from multiple institutions, and a small multi-institutional team is faculty has come together with a parent-led foundation that's agreed to fund their efforts. A data use agreement and IRB protocol has been developed by one of the collaborating institutions, and the department chair appreciates that families of children with rare disease want their data shared if it will improve outcomes. And she doesn't want to limit scientific progress or slow down faculty careers, but she also has to respond to the concerns raised by her legal and regulatory teams about sending limited protected health information to another institution for storage, about the reputational and financial risks of a data breach, about the potential for other children's hospitals to use the data for competitive purposes, and the governance of the economic benefits that might accrue given the value of the aggregated data set. The process for evaluation has gone on for months. Today, I'm actually not going to concentrate on the barriers to sharing, but on an example of how multi-stakeholder learning health system collaborations have achieved trustworthy sharing of digital assets at scale. My focus is on organizing principles for these kind of communities. I'll be describing some work that has its roots in the design of the American Board of Pediatrics Maintenance of Certification Program for pediatric subspecialists that was led by Paul Miles, who established improved outcomes in child health as the cornerstone of the process. And what Paul used to say was that doctors ought to be able to tell their patients what outcomes they could expect based on the last 1,000 patients like them. So our team worked with the board to design ways that would enable patients, their teams, and ultimately patients and families to integrate data sharing into the work that they do together and to build large communities that embody the ideas of the learning health system. The next slide. Next slide, please. Pediatric gastroenterology was the prototype for this effort. Gastroenterologists came together to form a network for Crohn's disease and ulcerative colitis that's now called the Improved Care Now Network. It has the mission that's illustrated on this slide of transforming healthcare and costs for children with IBD by engaging all stakeholders and working together to accelerate innovation, discovery, and application of new knowledge. Next, please. So this collaboration began in 2007 with 9 initial centers. The network has increased the percentage of patients in remission from about 60% to 82% in the absence of any new medications through sharing data, knowledge, and know-how. It's also continued to grow, now 109 care centers around the world with 40,000 patients, 1,000 physicians, about 2/3 of all the patients in the country with IBD. And next. And since we began, this learning health network model has been replicated across multiple pediatric subspecialties. Today, there are about 15 networks that involve 700 care sites, 300 hospitals across the US, and tens of thousands of clinicians and teams that are collaborating. And similarly, 700 data use agreements, 700 IRB protocols, business associate agreements. Go on to the next, please. The foundation of these multi-stakeholder, multi-center data sharing learning collaborations is network organizing. Networks are widespread, as we've discussed in our lives, from Wikipedia to Linux to TripAdvisor, and people self-organize around a shared goal. Networks are actor-oriented. They're organized around the needs and goals of the participants, and they provide a flexible, adaptive approach to realize the vision of the learning health system by making it easier to blur the boundaries between clinical care improvement and research. Network organizing has social and technical elements, and I'm concentrating on the social elements. The first is an unrelenting focus on outcomes, the adoption by the community of a shared aspirational purpose of exceptional, equitable health and well-being. The second is engaging everybody, patients, clinicians, researchers, and health system leaders in co-design of the effort. Network leaders focus on unleashing the inherent motivation that brings people to healthcare, their insight and their expertise to contribute to a community where everybody can make a difference. The third dimension is the shared platform, where we've been concentrating today on of infrastructure, policies, and processes. It's a system for creating and sharing data and knowledge so that people can find what they need when it's needed to make decisions and act in ways to improve health. And the last dimension is a rapid learning system, the scientific methods for improving care outcomes and conducting research. And the next few slides are examples from the Improved Care Now network to illustrate these principles. Just go on to the next, please. So network shared data is a way to build will and shared purpose. If you just click again, please, next, and twice. Thank you. Data about outcomes are shared in the network on a monthly cadence at virtually every internal and external meeting of the network, online and on public websites. This is an example of a slide that's from the biannual meeting of the Improved Care Now community that took place a couple of weeks ago with about 400 patients, clinicians, and researchers in attendance, and shows the improvement in the main outcome for the network, the percentage of patients in remission over 2 time periods. It highlights the improvement that's taken place over the last 7 years, an increase in remission from 77% to 82%. And we typically translate the results into individual patients, which in this case means that about 11,000 children are in remission today who weren't in remission in 2013. This unrelenting focus on outcomes is the building block for developing trust. Trust starts with shared understanding about what a collaboration will be about. Next slide, please. Networks are fueled by a small percentage of people who are motivated to contribute. They may be clinicians who've developed expertise in a specific areas. They might be patients who've come to live with a condition and have a desire to give back. Wikipedia has editors, networks have caretakers and curators who develop and steward the resources of the community to benefit others. In the Improved Care Now network, for example, youth with inflammatory bowel disease have organized themselves to create educational resources and toolkits which are posted on the website to help other patients live with the disease and make decisions. Patients actually recruit clinicians and clinical expertise to consult and advise them in the process. The next slide. Once the network infrastructure is in place, it can support a portfolio of activities. So we've collaborated with EHR vendors to develop tools to capture discrete data elements directly and directly upload them into the registry. Centers receive training to change systems, beginning with registry implementation and basic QI training through chronic care management approaches to increase the percentage of patients in clinical remission and sustained clinical remission. And then there are innovation communities that involve clinicians, patients, and researchers working on new initiatives. The network pivoted to focus on the COVID response for kids with chronic disease. And there are investigator-initiated and externally sponsored research projects. The next slide. And click one more time, please. This way of organizing has led to a culture and values, including those listed on the slide. The key concepts are agency, accountability, and responsibility, all of which are foundational for trust. And I'll note here that we use these same 4 principles in Southwest Ohio in real time over a period of several months to put together a data sharing and COVID response coalition across our region that includes 14 counties, 3 states, 22 health departments, 22 hospitals, 17 public health departments, schools, and businesses. Go on to the next slide. So data sharing in these kinds of learning health networks should be easy. They get good results. They're communities of practice in which all stakeholders are at the table and participate in governance. They embody the values of open research and knowledge sharing, and they're built on a foundation of trust. But yet, despite this promise, the adoption of the model is challenging. Institutions are not learning how to join learning health networks. It's a grind to get institutions to join. The administrative process is considered a success if a new member is onboarded in less than 9 months. This is true even if an institution is already a member of other learning health networks. Our inability to resolve these challenges is costing time and is impacting the lives and health of patients. Next slide. So what would accelerate progress? How do we help department chairs, administrators, clinicians, patients take a more holistic view of data sharing collaborations, their benefits and risks, so they can make better decisions about when and how to participate? It's an urgent problem now. COVID proved it, and it's not going away as we anticipate more ways of making data and analyzing data. So what should the department chair in our scenario do? What support does she need? We can't just keep going like we are by dumping contracts on lawyers. We have lots of experience to show that's not working. Our team is collaborating with Keith Porcaro from the Duke Center for Law and Technology to develop a set of initial tools that might accelerate progress, decision support tools and frameworks for evaluating how data collaborations are going. People and groups are charged with stewarding and data collaboration, and they need to be able to ask the right questions. A network nutrition label could provide a language for stakeholders who need to evaluate a potential partnership. We've begun to develop standardized labels that describe characteristics of networks that are relevant, the values and purpose of the network, the standards for data sharing, and the risks involved. This concept is similar to the privacy labels that Apple is using to help people evaluate whether to use an app, or nutrition labels from the Data Nutrition Project that's using data to help data scientists evaluate whether to use a data set for machine learning. These kinds of tools would help stakeholders have a way to make decisions that balance the goal of data sharing and benefits with its risks. The initial decision to participate is a bit of an artificial moment. Decisions support tools for a shared understanding is relevant at the moment of decision, but we also need policies and processes to support ongoing monitoring. Data sharing partnerships are like investment decisions. You don't know what would come out of them when you join. And so like any investment, they evolve over time, and we need tools and processes to support ongoing monitoring of investments in data collection, collaborations. This is perhaps something like the LEED certification, which is a concise framework for identifying, designing, and implementing practical and measurable attributes of trustworthy data collaborations. Tools and policies like these would enable multiple stakeholders to participate. They could place a focus on effectiveness and impact and provide transparency about outcomes achieved, the time it takes to get agreements in place, the use of data for intended purposes. The goal would be more empowered stakeholders who can participate more as equal partners in data sharing decisions. Next slide. Decision support tools and certification frameworks may get us one step closer to achieving more efficiency, more trustworthy, and more effective data sharing that impacts health. But why should we have to fight and grind one institution at a time when we know data sharing works and we just faced up to this challenge in COVID? National policy leaders can help by stimulating the development, as we've said, of tools and certifications because of the ability to convene, to set incentives, and to draft regulations to protect patients. We're all here today because of our shared vision of a learning health system, but in rooms like this, we don't have a continuous learning system. Beneath the national policy recommendations, it's the multi-stakeholder data collaborations that will have to make new approaches work. To accelerate progress, we need a system in which policy informs practice and practice informs policy. What's needed is a top-down and bottom-up process that links national policy efforts with collaborations, tackling real-world problems to allow adjustment of national policies in more real time. This is the solution-oriented approach that Dr. Cook mentioned. If we all agree that we have a moral and ethical imperative to pursue data sharing that drives better outcomes, how can we build a dynamic, continuous learning system that can keep pace with the advances in data and technology and that allows the effective policies to be developed?
Great. Thank you, Peter. That was terrific, and I definitely have some questions to come back to you on, Peter. So thank you, Amy Abernathy. Your opportunity.
Terrific. Thank you, Reed, and thanks to everyone for having me here to talk today about our learnings during our impact assessment on digital health in the context of COVID-19. My colleague Peter Lee has already started down the journey of telling you about lessons learned in our digital health exploration. And as we started that work, we thought that this was going to be predominantly the story of lessons learned through telehealth. And in fact, next slide, please. What we really found was that data without architecture leads to data silos. We really live in this massive landscape where we have had foundational and fundamental digitization across healthcare with the use of electronic health records, with the availability of many data and technical tools, but in fact, our ability to aggregate and leverage data at scale is not what we would hope. Next slide, please. And so one of the key outputs from the digital health sectoral analysis was the recognition that really we need to fundamentally think about what's the overarching architecture that we're all trying to build that's going to lead us to the available data that we're going to need for solving big problems in the future. And one of the things we did as a part of this working group was look at other examples beyond health. And I found one of the most helpful examples to be that of building houses. So imagine that you're going to build a house. You understand the architecture of a house and what you're going to build, but practically speaking, in order to build a custom house, track homes, in order to build a house in Florida or a house in Seattle, you're going to need the availability of skilled tradespeople, heavy equipment, building inspector, lumber, other elements of infrastructure to construct the house along your blueprint. And it's going to be important that that can be understood and there can be the appropriate modularity so that pieces can plug in, but also the sophistication and the ability to not only right-size your house, but also customize your house to your own needs. So there needs to be the ability to customize within these systems as well. So you need the ability to have enough industry standards and building codes and orchestration capabilities that electrical systems can be built, there can be plumbing and roofing, that you can actually get to the place of a livable house with windows in the right places. But there's also appropriate customization and the building capabilities, but also the business imperative to make sure that houses get built in Florida and Texas and Seattle to the specifications. And really that was one of the underlying themes that we started to think about in the context of what this might take for the future. And so we really thought about this concept that as we move towards trying to solve the problem of how do we get the data that we need for actioning our learning health system of the future, we need not only architecture, but modularity and the availability of data infrastructure. Next slide, please. So how might we get there? And one of the things that we really felt was important to say as a part of our working group is this is really hard. Practically speaking, the work that we've done as a nation around electronic health records is just one important step. But as you've seen by the different examples today, different groups are working on different aspects of a very hard problem. You heard about N3c and the work that they're doing to try and pull data sets together at NIH. We've heard about what's been happening at HCA, the important to work at Improve Care Now. And all of these are individual actions that inform how we might go after a larger book of work and way of thinking that may be one of the largest public health challenges ever to be addressed. We again kept looking at other elements across our personal ecosystem, identified everything from the interstate highway system to common financial system to the modern flight control system. And we acknowledged that all of these were well-served public-private partnerships. They asked for ongoing ingenuity and innovation, and they also allowed for greatly expanded economic activity for our country once these systems got built. They all required federal investment, and that's one of the key themes that we identified, but they all practically acknowledged this need for architecture and modularity, and to really be able to see the total landscape and how things might move forward. Next slide, please. So hard things are hard, but worth doing. I always like to remind myself that. And we have real belief that meaningful progress can be made. Big conversation today here is about data governance, and we've made incredible important steps in learning about key aspects that erode trust, but also build trust, that allow data sharing, but also prohibit data sharing. And we need to keep learning about what aspects of data governance are working and push those forward, but also continue to innovate on new aspects of data governance that we can put in place in the future. We also highlighted that there is the critical need to be able to think about the different components they're going to plug in. And Mickey brought up this issue of, for example, when we first started talking about electronic health records in 2009 and first started talking about digital apps, the App Store had just started. We're now in a place where we can think about data sharing and the data sharing rules. We can think about APIs for electronic health records and the ability to plug in, and we need to test how this is going to work. And again, push forward with those aspects that work and try and replicate and build, but also test new aspects in the future. The other piece here is the importance of modularity, that everything needs to be able to fit together, and that we need to be to shy away from a one-size-fits-all approach. Going back to building a house, not everybody wants to live in a 3-bedroom home, but we have to have enough modularity that everybody knows where to plug in their hairdryer. So importantly, we need that critical modularity. Next slide, please. So what do we need to do? We've been talking about data governance and trust, and these are really foundational principles that are going to need continued work. And I submit to you that we're going to need continued innovation in this space, not just to say that it's important, but we're going to need to keep stimulating innovation in this space. When NCATS was talking, for example, we mentioned the importance of synthetic data sets. Continued work to try and figure out how do we build privacy-sparing capabilities across our digital infrastructure. We need APIs, application programming interfaces, and other capabilities that create interconnections. We need to talk about data standards, but not everything can be a standard. Importantly, we need to right-size our expectations around standards so that we have standards for the right plugs, the right plugins, for the place where you plug in your appliance in the wall, but you don't expect standards for every element. All bedrooms cannot be the same size. In fact, if we have too many standards, we slow down innovation, And we make it almost impossible to envision all the places standards might be needed. And so in fact, we leave elements behind. We're going to need to keep working towards having more and more driver programs and projects, opportunities that let many flowers grow and test many different capabilities and see that many activities happening in parallel actually give us the chance to learn and look for convergence, things that work consistently across activities, as well as divergence, elements that are particularly good and stand out, create best in class, or elements that perhaps need to be left on the cutting room floor and we need to move on to something else. But it's going to be critical that we do that. We also need to think more and more about public-private partnerships. Data curation, for example, cleaning data is an expensive endeavor. Just because we share it and unlock it does not mean it's ready to help us make actionable insights, especially if I think about it from the regulatory perspective. High-risk problems require high-quality data and very, very careful analysis. And importantly, we're going to need to make sure that we have the business incentives across our overall data governance and data sharing models and our digital ecosystem that is going to allow all players to want to participate because they see business incentives and imperatives and the why in participating. The last two pieces that I would like to highlight is the importance of bringing all actors to the table. I'm struck today by the number of actors that we might need to hear from in the future to help make sure that we solve the problem. For example, more input from the tech industry as partners and problem solvers as opposed to vendors. And we need to have all actors at the table helping to solve the problems for the future. And we need to imagine developing more and more of the talent who knows how to use the data, clean up the data, and actually showcase the why and how this all gets built. Last slide. So a key area that our group focused on was how in the world might we do this? We proposed at least one solution, and this is just one way of thinking about this, that there needs to be an overarching kind of vision of where this might go. Thinking about continuously moving along a modular architecture, a data architecture from all sides that is focused on trust and governance, that is able to steward across all of our government elements, ONC and FDA, but also, for example, FCC and FTC, all the elements that we need to shepherd forward within the context of such an activity. It has the capability to facilitate vital public-private partnerships, similar to what PCAST could do, and has focused on advancing, for example, driver projects and other elements that promote and showcase what innovation looks like and can be in this space. Last slide. I think it's the last one. And so with that, we also highlighted a few other elements that we would need to make sure that happens within this space. We haven't talked much about cybersecurity today, but really, as we think about making sure that we have a trustworthy space, we need to make sure that it is secure and that it works for us in the future. And then we need to continue to think about how do we right-size the regulations in the context of this space to move things forward. So with that, I'll say thank you and enjoyed being a part of the panel.
Well, thank you so much to all three of you. Let me try to propose some provocative questions. I want to see how you all are thinking about these based on your presentations, and we'll try to go through a bunch of things very quickly. Amy, you really, this is going to I'm headed towards Mickey here, so get ready. Amy, you kind of, you know, as we start to think about this notion of how rapidly or not rapidly we are going to put these pieces together. And I really loved your ideas, Amy, around other industries that seem to have been able to figure some of this out. Mickey, why don't we have more government oversight, more muscularity on the part of regulation versus only letting the private sector kind of push through this? It's been a long time, Mickey, and it seems like our industry is very, very slow. Now, I will preface that by saying, I'm a private sector guy. So, but at the end of the day, the private sector has not solved this. How long can we wait? Why aren't y'all doing more?
Yeah, well, I'm sorry I haven't solved it in the 3 months that I've been here, but I'm, working hard on it. So I was in the private sector before January 20th of this year for 20 years in health IT. I'm not, I guess I would just sort of challenge one assumption that you just made, which is that it's been a long time. You can't have a phone network without phones, and you can't have an ATM network without ATMs. And it wasn't that long ago, it was just 5-6 years ago, that less than 50% of the provider organizations in the country had a functional EHR. So this has all happened very, very quickly, I think. And if you think about, sort of how interoperability has progressed and is progressing, I think that it does stand up to other industries when you, sort of appropriately calibrate and scale it. That said, that doesn't mean that we don't have a problem to solve, right? We do. I think that the main challenge is that the industry is so fragmented. It is unbelievably fragmented. And the government doesn't have the kind of role. I know, Amy and I have talked about this, that the minute you take a federal job is the minute that you get a hard lesson in what are the authorities that your agency has? What are the authorities that other agencies have? And you realize, oh, wait a minute, I can't just wave the magic wand. Amy and I can't just stand up and say to industry, we order you to do this. So I think that's a big part of the challenge. And I think Amy got it right, which is to say that this has got to be a public-private sort of endeavor going forward. And it's really about all partners. There's right now in parallel, I just came from speaking at a conference that Mayo Clinic is hosting called Partners in Privacy, which is a similar kind of thing, bringing together significant industry stakeholders to think about the ethical uses of data. So I think that there's a lot of activity going on right now, and we need to, sort of figure out how we're going to take advantage of that, bring some of that together to be able to have it congeal into something that can, sort of create some kind of collaborative model for us going forward.
So I'm going to push Peter a little bit on this now. And Peter, I mean, you've gone through a very painstaking analysis of how important it is that we have organizations and networks of individuals who are sharing visions, that are sharing processes, they're sharing procedures. Do you want more clarity? Do you want more guardrails that will facilitate that, or should every network invent its own?
No, there's the key to Amy in many ways was talking about it, Mickey was too. The key to allowing networks to form is in so-called actor orientation. So they have to be organized around the participants, but they need to be fueled by common infrastructure and policies and practices that enable people to get what they need when they want it. So there is benefit, a lot of benefit for us nationally to start to facilitate some of those pieces which are not being facilitated now. A big missing connection that I tried to highlight is the opportunity to more directly engage with or groups that are facing these challenges as they're facing them, to couple the policy development with the solution creation.
And Amy, let me get you in on this as well. So if we figure out where the plugs and what the size of the plugs should be for Peter's network, but you create your own, and we want to plug and play. If I can figure it out for Peter, but here you come along, how problematic is that?
So, it is a challenge. Now, for example, with the NCATS, the N3c example from NCATS, they did create translation tables, for example, that, essentially allows you to plug your hairdryer in Europe and also in the United States at the same time, right? So there are opportunities to still work even in systems that don't have perfect plugs. But I think that we are going to have to be smart about which elements we need to standardize. I often think about this kind of core concept of surgical strikes for standards, where you really want to really be thoughtful about which elements you want to spend a lot of time getting buy-in and standards about and promulgate throughout the system, because that process is very expensive if people have to switch off of what they were doing before. And also you're going to end up with a lot of naysayers. And so the amount of time and energy and cost that goes into adopting those standards has to be balanced against the value of the standard. And so those plugs are going to be really important for us to get agreement around. I was listening to an ONC high-tech meeting last week as ONC was thinking about some of the standards that they're defining. And, I think it's a really important conversation to really define specific standards, but be careful about going too far. And that was actually part of the conversation was, let's get skinny standards, so to speak, and beware of asking too much.
So Mickey, let me come back to Mickey on this then. And by the way, you and I if I see you one day, I'm going to still say I'm not going to agree with you that we're going too slow, that we're going fast. I'm telling you, man, it's been a long time. I don't know what your yardstick is, but we'll fight over that over a Pepsi or Coca-Cola or something. But listen, man, on this point that Amy is making, how do you sort of see in your role now the opportunity for you to prioritize what are the most important standards, and how do you sort of see that going, given that we can't do everything at once, but you got to do the right things first? How do you see that going forward, and what's the process that you're going to get that input from?
Yeah, so you may be surprised to hear me say this, since I'm, in my role, I'm generally thought to be the standards, the standards nanny. But I completely agree with Amy on this, which is to say that there are a certain set of things that now are instantiated in what's called the US Core for Data Interoperability, which are about things that we ought to all have a common expectation that when you go and query a record for a general purpose case, that you ought to have a basic expectation about what you're going to be able to get back, and that's based on a set of structured data elements. And what we want to do with the US CDI is have that be a rising floor over time. But I guess I agree with Amy. I would frame it in a slightly different way, which is to say that if that is going to determine the pace of innovation, then we may as well all just give up, because that cannot be the rate setting, step or the rate setting thing on innovation. And so I think I would just point everyone to that a part of the information blocking rule is this concept of Ehr, electronic health information, which is right now for the first 18 months, it is limited to, or it's defined as the US CDI, which are these structured data elements. But after 18 months, the requirement is that all information, and I'll put that in quotes because I think as everyone participating here knows that all is a very slippery term in a medical record, but it does say that the electronic components of a designated record set need to be made available by the provider and the technology vendor, and most of that's going to be unstructured. And I think all of us as an industry need to start thinking about what are the tools and the processes we're going to put in place to be able to get and make use of that unstructured data through advanced algorithms, bring together multiple data sources, all of that. So I completely agree with what Amy's saying on that front.
Well, before we agree too much, let me just ask you. Let me see what trouble I can stir up here. Do you really want to and believe that she's right with an Office of Health and Healthcare digital integration? Didn't she just take the bat out of your hand, my friend?
Well, I'm not going to get into that. Amy's leaving, so we'll figure out how to clean that up. Just joking, Amy. No, I mean we're working together. A big part of, and this is an underappreciated by me at least, part of the job of the National Coordinator's Office is the role of coordinating the federal partners. So going back to your first question, which was how come we don't have sort of general governance from the federal government? I think a part of what I see as as our job in particular role from ONC is working with the FDA, with the CDC, with HRSA, with ARC, with VA, DOD, to say how do we all sort of take the same approach so we're rowing in the same direction, which in the absence of formal governance can at least be a market driver toward a consistent way of doing things. And right now, I think we don't have that as much as we like.
Thank you. Peter, you talked about some of the processes by which networks would come together and elements, but one thing you didn't mention in that list, and I wonder if it's important, and that is the willingness of the partners to share risk. If you have different risk tolerances within these organizations, you got somebody's corporate counsel that's a more scaredy-fraidy than someone else. How big of a challenge is that?
That's an immense challenge, and let me just talk about the social aspects of building these kinds of communities. I think the cornerstone of building effective communities is what we call the unrelenting focus on outcomes. So if we were to evaluate our progress in making data sharing a reality, we ought to evaluate it based on whether patients are actually healthier, demonstrably healthier in more or less real time. We can measure the outcomes that we're achieving in populations of patients on a monthly or quarterly basis to see whether or not the changes that we're trying to put into place are actually having an impact. That focus on outcomes when we start a network focused on when we started our network focused on hypoplastic left heart syndrome, it was the parents who said, who were the driving force behind the focus on reduction of mortality and absolute sharing across institutions. And it was the parents' voice around the kind of aspirational impact that needed to take place that started to move the institutions to give up a little bit on the risk perception. So starting with that long-term focus, very aspirational, very impactful, and then bringing along a small community first who are willing to go for it, they'll attract others, set the culture, and start to reduce the friction, some of the friction around data sharing.
Good, thank you very much. Mickey, one of the big challenges, and I'm sort of looking also at some of the questions from the audience, but one of the big challenges that we have in this moment that was clearly highlighted by the pandemic is the notion of the distrust that so many different sectors of American society have now with government, with healthcare, and so forth. How worried are you that the more that individual data is now going to be consolidated, aggregated, and incorporated from so many different parts of our lives? How concerned are you now that it seems like almost a tsunami of distrust is going to frustrate our ability here?
Yeah, I mean, I'm worried about it for sure. I'm worried about the gap that we have right now in the policy framework that hasn't kept up with technology, as I pointed out before, that we don't have a general data policy to be able to cover where this data is now landing increasingly. So I think that that's a really big challenge for all of us. So I think it is definitely a concern. The one aspect of that is allowing patient control of their data. But without the appropriate protections around it, that's sort of limited in terms of how much control do they really have when many I think, as all of us know, in our own personal experiences using apps and things, we get essentially commercially coerced to make our data available in ways that that maybe we don't fully appreciate for the purposes of convenience or whatever it is that we want to do at the given time. So I think that's a challenge. I think that that the open area right now about the state of de-identification, if it even exists anymore, is a huge challenge as well. So I think those are big concerns. And there's a big policy gap right now that we need to figure out how we're going to fill.
Would others like to comment on that at all?
I just fully agree. I think this is also the space where we need more innovation. We're going to need innovators to come up with new solutions to try and solve for privacy sparing.
Great. I would make the observation as well that if the COVID work that I'm getting the privilege of doing is really highlighting to me, and it's not a unique observation for, I don't think anybody even, is that facts don't always matter. What you say doesn't matter. There is just a number of conspiracy theories that are going around, and I just think it is inevitable that we're going to get caught up with people being mad at Facebook, people being mad at whatever site there is out there. And I think what this is going to call for, Mickey, at some point, is going to be a very needed public service campaign that will, once we get through the pandemic, that's going to start to get at this. I don't know if that's overwhelmingly provocative, but I don't think this is something easy that can be done. Peter?
I just want to come back to the thing one thing that engenders trust is people's belief that the use of the data is actually producing demonstrable results. In our community in Southwest Ohio, 2.2 million people, that started with daily reports and across a variety of sectors of data that was localized that people could understand and feel and were using. And what we've observed as a result of that is every school system in the community, every hospital system, all the public health departments, the newspaper, the business community actually coming together because they started to trust the results because they knew that they were locally representative.
Good. By the way, in the chat, Deborah Duran is also once again to make sure that we continue to advance this concept of getting people to have confidence enough to have a mind share to share as opposed to the investigator owning somebody's data. But I think these are going to be huge challenges. In this regard, there are members of the audience that are interested in the role of HIPAA. Are we going to need now to do more to either communicate what HIPAA sanctions or not? Because I think there's a lot of people that really still are confused about what the rules are and the constraints are for HIPAA. So do we need to better communicate, or do we also need to do something new about the prohibitions and or protections of HIPAA that will allow us to aggregate more of this data? Who wants to comment?
I'm going to start here, and I'm going to say it's both. We're going to need to contemplate new protections for the future. I think it's going to be contemplated for us otherwise. And one thing I just want to say is that we've been talking mostly about EHR data, but what we learned through COVID is that this is data from all different sectors and the importance of all of those data sets coming together. So there's the issues around HIPAA, but HIPAA is only one part of this story. And as we think about sort of the data that's going to be needed from a learning health system, we're going to need biologic data. We're going to need data from social listening. We're going to need data from all these different spaces that's going to also be part of this story.
Others want to comment, please?
We've wondered whether there needs to be the role of no moral hazard, whether the federal government should have what amounts to a vaccine injury compensation act that enables us for people whose data are used and there's negligence, a way of balancing the moral imperatives to use data to improve health with the risks that something bad actually might happen.
Good, interesting. Mickey?
Yeah, I mean, so there are definitely, sort of these challenges of the boundaries of HIPAA, being tested. I don't think in some ways that shouldn't surprise us. Remember, HIPAA was passed in 1996. Anyone who thinks that a law that I would argue has served us pretty well over a long period of time ought to still be applicable for the next 10 years, given everything that has happened, in the world of technology, in the world of individual enablement of data, and the data of fluidity that happens outside of healthcare. I think that we're just sort of kidding ourselves and thinking that that there aren't those changes needed. I mean, I think one challenge is how are we going to muster that national consensus around a general data privacy law? As we know, that's we can't even get the Congress to agree on a nationwide patient identifier. So the thought of having sort of a general governance is is sort of a challenge in general data privacy law. But that said, I do think that that there are ways of thinking our way through some pieces of this, but I think we do need to recognize, as Amy pointed out, that the inferred medical record information that one can draw from all other parts of it mean that if you're on that side of it, and let's say you're on the outside trying to put together some kind of profile on you or me or Amy, the medical record that is the formal medical record is really just a piece of the puzzle. It's not the whole thing. You sort of take my search history, my location data, all of the other things, start putting that together. You can start to put together a pretty good medical profile without any medical record information. So I think that's the way the industry is looking at it. And we need to recognize that, that whatever we put in place needs to think about it through that frame.
Let me see if I can challenge you all again with a different kind of question. We have focused our efforts here on the complexities of so much of the digitalization of our health and healthcare data. One of the things that Mike McGinnis has been leading us all through on the National Academy's Learning Health System has been to be thoughtful about the transition from fee-for-service to value-based reimbursement. inevitably, value-based reimbursement will require delivery systems to be attentive to the social determinants of disease as we use data and information to identify people early in their risk factor profile and catch them and then intervene before they flip over into getting sick and then not only having bad health outcomes, but screwing up the financial profitability of the venture as they get reimbursed. The point then becomes, how are we going to start to handle the social determinants data? How are we going to be able to link in all that stuff that's the non-medical, but non-medical, but medically necessary social support information? Are you envisioning that happening as well? And anyone can take that.
I'll start because I was struck by your comment to Mickey, which was important about taking the bat out of ONC's hands. And actually, when we suggested something like OHDI, this wasn't about taking the bat out of ONC's hands, but acknowledging that really as we're building the digital architecture for learning health system, we need to acknowledge the need for data sets way beyond the electronic health record and traditional healthcare data. And so it does include social determinants of health. It includes environmental exposures and environmental data and other types of data sets that really are critical to helping to think through what does health mean and how do we have healthcare delivery, and improved health. The other thing that I'd highlight as it relates to this is you hit on value-based care, and practically speaking, especially as I imagine more and more personalized health interventions, we're going to expect those interventions to have meaningful impact at an individual person level and being able to document that impact. So being able to have systems that can showcase outcomes and make sure that the interventions that people are getting are the ones that work for them is going to be a part of the system. And so that we're going to be able to make sure that outcomes are a part of how the system is built kind of going forward. So those are two things that I would highlight here that I think are going to be important.
Yeah, let me just add that I think while we think about policies and technology, we need to think about community building and the work of truly getting all stakeholders at the table from the beginning to envision how this might work and then actually making it work together. It's out of those interactions where people can have these kinds of honest conversations that trust grows because we're demonstrating what we can do, not in an abstract way, through direct results that take place. And one could imagine the political process is all about community building, but why don't we use a little bit more of the political community building process in tandem with the policy development process?
And as Mickey, as you sort of get your oar into this one, I wonder, are you having on this kind of an issue, or is it, of course, you only been there a minute, but are you having conversations between where you are brokering CDC and CMS to say, hey, let's talk about how this might work?
Yeah, so we are in constant discussion with CDC, CMS, FDA, all of our federal partners around data in general, and this is just one, sort of element of that. So, and going back to your original question, Reed, about social determinants of health data, that's already happening. I think that's the reality that all of us need to face here, and it's a part of the challenge of the technology racing out ahead of the policy. But there are nationwide networks that I don't need to name the brand names of them, but they're big and they're growing and they're investor backed and they are out there doing it. They're collecting that data. I used to work for a population health management company, and we were making connections with those vendors. And there's a whole bunch of stuff that that falls under a business associate agreement. There's stuff that's in a really gray area, and that we all try to work together in the best ethical way to approach it. But that's just one example of the challenges that we face.
Great. Diane Lewis asks a question of you. Where do state regulatory paradigms fit with the roles of the private and federal payers? As if we don't have enough folks in the game, how does that work?
Yeah, I think
everybody likes the states.
Yeah, I can take the first shot at that. And I'm just going to say I'm going to have to drop off in a minute because I'm speaking another thing right at 12 noon. But I guess that I would just point out that is one of the key challenges that we have with respect to these governance questions, right? I mean, and it traverses everything. It's not just interoperability questions and about data sharing and data governance. If you look at public health, it's just one example. Part of the complexity of public health and our ability to have the kind of public health response that we were wanting to have during COVID is related to the multiple jurisdictional levels and the lack of full alignment and orchestration, and ability to orchestrate all of those jurisdictional levels.
Hey, Mickey, thanks so much, man. I know you got to go. We
Thank
really
you.
appreciate your, thank you, man.
Thanks
Okay.
a lot.
We have one more question that maybe somebody might want to see if they want to take, and this will be our last one. But Robert Phillips wants to know, what is the parallel on the federal data strategy side for HHS agency data? It seems that data connectivity internally needs some of the same governance and will be important to then connecting federal health data assets to private sector health data. Who leads that charge?
So I'll take some of this, I represent FDA on today's call, but there's been an HHS effort within the context of COVID to start to connect across the operating divisions within HHS, so across CMS and CDC and FDA, et cetera. I think it is still early. There have been prior efforts, but probably the one in COVID is the most mature at the moment, teaching us kind of how to start to do this work. But I would say that we've got a long way to go in really learning how to leverage data across HHS, which is just one part of, I think, a very big story that we're going to need to push forward with.
Thank you. Peter, any thought or? All right. Well, listen, this has been a terrific panel, and I think that we've clearly, you guys have really clearly highlighted important points. I think, Mickey, I think it is very important that we really do have to keep zoning in on how do we deal with de-identified data, and can that actually be, can we actually accomplish that? That is going to be challenging. I think you're absolutely right. We need guidelines. I think you're absolutely right that that we have to figure out whether or not contracting mechanisms are a useful tool, and then whether or not we can have data governance rules to be established inside of these networks. I think Mickey was right there, and Peter, you picked that right up immediately and said that the way in which we get these data governance rules really do need to have multi-stakeholder collaboration, and it has to be reflected in the organizing principles with which they come together. I sure wish that that story that we could sit down with a patient and say, I can tell you exactly the best course of therapy based upon dealing with thousands of people who have exactly what you have. I sure wish, we've been talking about that dream for years, and I just can't wait until we actually can manifest that a little more strongly. I think your notion of focusing in on a shared vision is important. I think that shared vision thing, Peter, is not only a shared vision for what you want to achieve, but also in the sense of the responsibility and accountability of the participants to move it, to get it done, to not let arbitrary barriers stand in the way, and realize that we've got to be able to take this digital dividend that my friend Jonathan Perlin always teaches me to say in every one of these meetings. Take that digital dividend and apply it in real time now to improved healthcare outcomes. And so that vision of not only what we want to do, but the urgency, I think, is very important. I think you've clearly laid out important things on shared infrastructure and policies. I hope that your point on continuing improvement pathway, that there is actually, it is adequate, that actually you can look at continued improvement and it actually can do something and in real time. And then lastly, I think you made a very important point about the barriers in terms of the time it takes, and maybe a certification framework like the LEED certification may be a good model. I think it's one that needs to be dealt with. And finally, Amy, I thought again that your idea of I really benefited greatly from your notion of the other industries and how is it and what it is that other industries were able to do. It does make me crazy that I have had my ATM card for a bazillion years, and I ain't got diddly squat when I broke my ankle and needed to get a doggone X-ray to my provider without taking my broke ankle and going to the hospital and getting the doggone film and walking it back over to some doctor across the street. That's insane. So I think that was extremely important. I wonder whether there's a role for the National Academy of Medicine in being able to deal with this issue, this challenge, Amy, you gave, of it's like everybody's looking at the same elephant, and somebody's looking at the nose, and somebody's looking at a foot, and somebody's looking at the head, and everybody's working on their piece. But how do the pieces come together, and who has the overarching framework? Maybe that's something for the National Academy. I think finally your provocative notion on the rapidity of digitalization of information is what sparked me to talking about the social determinants and how do we get that in. And then finally, I'm glad you didn't get mad when I said that maybe the idea of the Office of Health and Healthcare digital integration was taking the bat out of the hands of of that office. So I was just trying to mess with you a little bit. Thank you all for the opportunity to moderate this. Mike is going to take it on and provide the summaries. But Mike, I tried my best to give you a head start on summarizing at least our section of this and maybe making your summary job a little easier.
Well, you're terrific, Reed, as always. Thank you very much, and we'll loop back with you. I do want to have, actually, we're going to have a little discussion here, and I'm going to ask Amy Abernathy to serve as the surrogate head of ONC, since the appointed head of ONC has had to go to another meeting. But before I do that, I'd like to move over to Jonathan Perlin to offer any reflections from his perspective. Amy, I'll just give you a heads up on what I'm going to ask you. Essentially, we've heard at least from my list, that there are 4 arenas that especially need attention as we're building out the architecture that Peter Lee described for our data domain. One of them is the module, the elements of the building you've described as that we're building. A second is the interfaces between those parts, how they fit together. A third is the standards that are used in order to ensure the integrity of the elements and the interfaces. And a fourth, which is a variation really on the third, is the whole issue of privacy and how we contend with that. Although it does deserve its own attention. Clearly, we need to develop priorities in each of those areas as we're moving forward as a national system for data governance. And one example, I think it was Mickey who mentioned this, of ways in which we can actually force progress, at least theoretically, without additional legislative authorization, is what happens with the federal organizations, the federal agencies involved, the DoD, the VA, the federal healthcare facilities, and so forth and so on. Actually, there's a sort of twin element that we can ask Peter Mogurlitz about, and that is how you would do it at the local level. But let's say that you are able to, with your new organization, with a real big bat at the central level, how would you pull those federal agencies into a critical mass of data governance that would make a difference? So think on that for a little bit while we go over to the co-chair of the Data Health Action Collaborative, who was able to join us and wasn't here able to earlier, Jonathan Perlin. Jonathan, thanks.
Well, Michael, thank you so very much. And I only wish I could have been with you earlier today, but I think you heard a little bit about what we've been up to in our public-private academic partnership this morning. First, let me just say what a brilliant panel, brilliantly moderated, and so many important points that were made. I want to thank all the panelists and Reed for just creating such an engaging dialogue. It led me to 3 observations. The first is a sort of philosophical issue, and perhaps one that is a key role for the national academies. And that's that I think we use privacy as shorthand for a broader philosophical divide between that sort of beloved American rugged individualism versus something we see elsewhere, which is really attention to a common social good. I know as part of our learning health system concept, and one that really framed the work that you heard about this morning, there's this notion of a digital commons. And I think perhaps privacy and aspects of privacy need not only technical fixes, but need to have an elaborated conversation that allows us to begin to realize the benefits of secondary uses of data. And the project you heard about, it was really accelerating answers to the understanding of COVID and its treatment. Which leads to a second concept, and it really builds on Amy's and Peter's terrific comments about enough standards, but not so much that they're constraining. And that there's really seems to be a reciprocating relationship between sufficient standards to be able to use as tools. We couldn't have created, for example, the data warehouse that ultimately led to a curated clinical data set that ultimately led to a capacity for noise injection, differential privacy, and that sort of thing, without a sort of core of standards that were elaborated a decade ago. But at the same time, it's clear that there are learnings from this sort of practical application that might actually help to prioritize what are the next set of sort of min-spec standards that allow us to move forward. Behind that is a secondary question about what then motivates, whether it's broad social good or other opportunities. I think characterizing the sets of incentives is particularly important. And third, I think the unifying aspect, again, a role for the National Academy, certainly for our policy leaders, is what is the vision? And in a broad sense, I don't think we can answer the grand challenges like supporting health equity without, as was indicated by Reed's question, really attention to the social determinants. And so, the system at design, the standards and incentives and framing need to be oriented toward a capacity for measurement of both health and health outcomes, to Amy's point, because really this is, I think, our 21st century opportunity to accelerate learning, not just real world evidence in an abstract sense or done uniquely in certain partnerships, but really as a very intentional product of a system that's sufficiently defined to really catalyze further development, but not so overspecifies that it really retards capacity for innovation and progress. These are really big questions, and I think it's really in the convening of the different perspectives that the National Academies can bring together that we may be able to offer insight. But just to be really sure, whatever you might have heard or thought about the charge initiative that was described this morning, the truth of the matter is that the nidus for this idea wasn't formulated during COVID. It was formulated around the table of the leadership consortium more than a decade ago, as we really talked about what's necessary for learning healthcare. So thanks for the opportunity to offer a few comments.
No, thank you, John. Amy, what working groups would you put together? How would you make this happen at the federal level? And Peter, just to give you a heads up, after Amy's talked about what might be possible, how we might approach it at the federal level, it would be interesting to build on your thought about what's necessary at the local level to facilitate progress.
Yeah, at the federal level, first of all, I think Jonathan really summarized a lot of what I was thinking as I was, you'd given me this charge. And the other part of this is that you highlighted in your comments, Michael, and what Mickey said, that we do have essentially a federal proving ground, and that best federal proving ground is the VA system, right? So as I think about the opportunities within the context of the VA system to test out ideas and to be really explicit that this is our opportunity to really showcase what's possible. A couple of elements on the federal level, though, to go back to the 4 areas that you hit on. So you highlighted modularity, you highlighted standards, you highlighted privacy, and you highlighted essentially connections or APIs. And importantly, I think at the federal level, we need to do a number of things. We need to continue to work on what's that short list of standards that we think are really going to truly matter, and then test some of those. And one of the examples that I always use that I think is a great example of an unlocking standard is universal device identifiers. And a universal device identifier will unlock a ton of use cases, and is something that certainly at the federal level we've been talking about for a very long time. And so importantly, working on that standard and continuing to work through what it's going to take. But then, for example, within the VA system, pressure testing what it looks like when we put that kind of a standard to work, because what else is going to be needed beyond just that standard? And we're just learning from individual projects that have been pushed forward. And Jonathan was talking about sort of that need to learn from the individual activities. It's more than pilots. It's actually, that's why I called them driver projects, because there's a critical need to actually have them drive forward. What else do we need to do or know after this once we've had this set of activities? So I think I would, at the federal level, define some of our unlocking standards and make sure we're going after them. ONC has started that, but I think we have a number to continue to move on, and then pressure test what happens when those standards are put in place in systems. The other part of what you mentioned was APIs. The VA right now has a really terrific system that they're really trying to push forward with a number of API-based activities across the VA, as well as some public-private partnerships. And I would continue to promulgate an API-based approach, testing in VA and other federal environments, but then continuing to push beyond. But importantly, as we do that, and for example, we can leverage FHIR and other activities, we really need to understand what the APIs that we have right now and the approaches that we have do for us, and what needs to be continued to push forward. So at the federal level, one of the things I think we need to do is really be very thoughtful about how the system is moving forward. When do we get out of step by not paying enough attention to privacy or social determinants of health? And when does too much attention in one space mean that we don't keep in step with developing, for example, the right standards for the right moments in time? And that's going to be a really important aspect at the federal level, to have the ability to keep an eye on kind of across without essentially limiting innovation. One of the key aspects here is to be able to promote innovation across the system. So I'll stop there.
Thank you, Amy. Let's go to Peter for the ground up perspective. And as we move there, if we can, it would be nice to round out the session by hearing briefly from each of our speakers and moderators, the co-chairs, about what they think they'd like to, it comes to the issue of what the NAS might be able to do. And one thing, and the National Academy of Medicine, one thing that we can do, of course, is think about a consensus study that would help to lay out the vision that John has referred to, and would help to identify the key issues that need to be clarified, help to identify the strategy, make recommendations on the kinds of things that could happen and what pace. So it'd be nice to hear from you about what you think the most important elements or element, pick your favorite, of a statement of task for that kind of a study might engage. So Peter, back to you first, for the ground up view.
Yeah, thanks, Michael. Amy there's this tension between what do we do at the technical and policy level with what happens at the ground was making me think about what took place in our region. Again, 2.2 million people, Southwest Ohio. And we noticed that we came together in new ways using these principles. And so that made me think about three things. One is motivation. The second is how to make the problem tractable. And the third is where to start. So we often talk about incentives. I think we sometimes don't give enough attention to motivation. As people who live in communities, we care about our communities. We care about the health and well-being of our communities. We need to, it's a matter of leadership to amplify and build on that capability. The second is there are, as we've thought about this work and what takes place based on the trust that's developed here among many stakeholders who often didn't connect, we've started to think about what are the future epidemics in which we're going to have to use these capabilities, mental health, opioids, social determinants of health. How do we actually take the momentum that we've got now and build on it? If there are roughly 400 metropolitan statistical areas in the country. So that starts to feel like something that actually is tractable. It's not millions, it's somewhat tractable. And then from a community building perspective, within that 400 communities, some places are doing better than others. Those are the ones that we want to concentrate on and start to elevate and perhaps even help so that they can be the guiding lights for others who can follow their leads. They're the innovators, and we can make a little bit of progress in that way. So those are some initial thoughts.
So one of the things that we might think about doing as the National Academy of Medicine or other organization for that matter is facilitate some activity among those 400 metropolitan areas to develop essentially a strategy template of it won't fit for everyone, but there are certain elements and principles. We'll come back to you on that. Let's move then, if we can, to ask each of you who were speakers and co-chairs, just to give your top of mind thought about the ways in which you would like to see the National Academy of Medicine facilitate progress in this arena, including what elements might be in a consensus study of some time. And Rich, can we start with you? We'll go first to the co-chairs, Rich and Rick. I guess Reed's gone. John has made his piece, but we'll stated his piece, but we'll see if he has anything else said. And then we'll go to Ken and Sarah, and let's see who. I think we've hit the rest who are still here.
Okay, thanks. So I'll say we might broaden the conversational frame a little by talking about health information sharing rather than health data sharing, because what we really care about is the information rather than the data. And I think that clears the way for having a deeper conversation about the relative merits of the two models that were presented today. That is, the data stays home and the question comes to the data, versus the data is centralized so that it can be used all in one pool. And I agree that with Ken that there are pluses and minuses to each of them, but I haven't seen any really good consensus statement that really lays out those pluses and minuses. And so I think that would be a terrific thing for the Leadership Consortium or the National Academy to take on is guidance that's sufficiently detailed so that when you're thinking about fitness for purpose, you can make a decision about when it's important to put the data together versus leave it separate.
Thank you, Rich. Rick.
Well, I think there are a lot of opportunities for National Academy of Medicine to lead here. And I think a lot of comments have been made so far for great suggestions. I just want to highlight the fact that I'm just overwhelmed by the progress that's been made so far. I mean, we really are starting to get a drink from the water all around us. And it really is very refreshing to be able to see the progress that N3c has made, and also the Children's Network. So we know that there's a proof of principle here. We can actually do this. And I think probably one of the most valuable things that NAM can do is to kind of summarize and put together those successes so far to be as leading examples for us to go forward and develop. I'd like to get a little bit more detail about the methods about how these were accomplished. And I think that might be a nice role for us, is to be able to get an open, transparent display of what's worked, to be able to compel and provide impetus for us to go forward. But again, super impressed by the progress being made so far.
Thank you, Rick. John?
Well, thanks, Michael. As you said, I've made my piece. I'll just add one more thing, which is that as we think about health being more than the aggregate of healthcare data, to Rich Platt's point about the difference between data and information, and to the comments that were made about the importance of social determinants. As much progress as we've made, even with the limitations in the formal healthcare environment, it's really stunning how disconnected, fragmented the public health information infrastructure is. And as the administration contemplates infrastructure investment, can't help but think of digital bricks, digital infrastructure, and the opportunity for the national academies as part of this to really contemplate not only with the lens that we've discussed, but also embracing a, for lack of a better term, meaningful use for public health that begins to complete the picture of health, not only of the individual, but of communities and of our country. So I would hope that there may be some opportunity and receptivity to insight on how not only one might elevate the public health data, but how in terms of the better health outcomes that comes together with the structure defined thus far. Thanks.
Thank you, Jonathan. Ken?
Hi, thanks for the opportunity to speak. And, I think the things that strike me as most important are greater guidance on data privacy and approaches to that. We've been largely determining a way to approach that on our own, and some guidance would be helpful, as well as the ongoing conversation about data standardization. And I think about our own efforts nationally to create a standardized data set across multiple states, and how difficult it was working, for example, in the vaccination environment when every state had a different standard, and the loss of signal that was created by that emphasizes for me the need we have for greater approaches to standardization of data sets.
Thank you, Ken. Sarah?
Sure, thanks for the chance to comment. I think this builds on both Rick's and Ken's comments. We have networks, we have collaboratories, we have models, but what we don't have is a comparison between, how these different networks have gone about building trust, establishing incentives, gone about decision making. And I think that there are some best practices that could be gleaned from a consensus study. And then the only other point I'll add is that we need to think about sustainability of these. A lot of these there's a dependency on often federal funding, but whatever we come up with, we need something that has some true sustainable way of becoming an enduring part of the fabric of health data.
Thank you, Sarah. Peter, if there's something else we'd like to hear from you, and we're going to give the last word to Amy. Peter?
I'm ready to give the last word to Amy.
Okay. Well, as we hand the baton over to Amy, we want to do it with deep thanks and appreciation for your service to the nation. Amy's last day as the as a deputy commissioner at FDA is tomorrow. And she has, in her time here, been a wonderful force for progress, and obviously is going to continue in that vein as a force for progress. But we certainly give you our very deep appreciation for your leadership and for the partnership.
Thank you very, very much, Michael. I'm honored, and I'm really honored to be a part of this conversation. As you contemplate potentially doing a consensus study in this space, I encourage you to continue to think about the elements of data architecture that we've talked about. And I think Sarah's point about looking at the different examples that exist and what's been working across those examples will be helpful. I think the other thing that we've got the opportunity to do is take the example of events that have happened across time, CA Big, our high-tech investment, the collaboratory, et cetera, and really spend time looking at each of these and understanding how they've helped us move the conversation forward and how they've contributed to getting to where we are. And just the sort of remarkable digitization that we've been hearing about today is certainly the byproduct of high tech, but also what else has it taught us about what else is needed, and get really explicit about that. I think this issue around data architecture and modularity will come through, but we may also learn, critical elements around the sequencing and the order of things that we're going to need to do, that if we do this, then it uncovers the following 3 things that we're going to need to contemplate next. I'll give you one last example as I think through this, which is that as we have more data availability, Rich mentioned information. It's that as we have more data availability, I'm just going to use that as my example, we're going to need to now develop the new scientific methods to be able to use it for a variety of use cases where we're expecting to put it to use. And we're going to need to make sure that we contemplate how we're going to develop those methods, because I submit to us that we don't really have all the methods in our toolbox yet. So, that's just an example of what I think will happen with that. So thank you very much. And it's been an honor to be with you.
No, thank you on so many dimensions. And thanks to all of you who are still in the audience. As I repeat what I said earlier, and that is, please send us your suggestions and questions. That's the way we learn, and that's the way we forge our path forward, is by hearing from you as a larger support network and engagement network for our work in the National Academy of Medicine. Thanks in particular as well to the staff involved, to Ariana Bailey, who has been negotiating all of the logistics of our meeting today, to Laura Adams and Nora Ahmed, who have worked on the front lines with the co-chairs to forge this wonderful agenda, Elaine Fontaine, Asia Williams, and Mike Cocciola, who have all been very much engaged in it. So applause to all of them, and thanks to all of you. To be continued, and keep those ideas coming. Be safe, be well.
Thanks, Michael.
Mm-hmm.